Welcome to the New Chemists podcast. We are so glad you are listening.
Welcome to the New Chemist podcast.
Bienvenidos al podcast del nuevo químico.
Καλώς ήρθατε στο podcast του New Chemist. Welkom bij de podcast van The New Chemist.
Bienvenue sur le podcast du nouveau chimiste.
Bem-vindo ao podcast do novo químico.
Welcome to the New Chemist podcast. Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here, rooting and cheering for you. Don't give up.
Travaillez dur. Soyez axés sur la valeur. Tu peux le faire. Vous pouvez grandir et l'apprendre. Vous pouvez être la différence dont vous et votre communauté avez besoin. N'abandonnez pas. Nous sommes ici pour vous encourager et vous encourager. N'abandonnez pas.
Trabalhar duro. Seja orientado por valores. Você consegue. Você pode crescer e aprender. Você pode ser a diferença que você e sua comunidade precisam. Não desista. Estamos aqui torcendo e torcendo por você. Não desista.
Δούλεψε σκληρά. Να οδηγείτε στην αξία. Μπορείς να το κάνεις. Μπορείτε να μεγαλώσετε και να το μάθετε. Μπορείτε να είστε η διαφορά που χρειάζεστε εσείς και η κοινότητά σας. Μην τα παρατάς. Είμαστε εδώ για να σας ζητοκραυγάσουμε. Μην τα παρατάς.
Trabaja duro. Sea impulsado por el valor. Puedes hacerlo. Puedes crecer y aprenderlo. Usted puede ser la diferencia que usted y su comunidad necesitan. No te rindas, estamos aquí animándote y animándote. No te rindas.
Werk hard. Wees waardegedreven. Je kunt het. Je kunt groeien en leren. U kunt het verschil zijn dat u en uw gemeenschap nodig hebben. Geef niet op. We zijn hier om voor je te roten en te juichen. Geef niet op.
Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up. Thanks for listening. We're glad you were able to tune into this podcast. Once again, this is The New Chemist, where we discuss chemistry, which simply put is the science of change, as well as the other sciences, careers, community, research, and COVID-19. Thanks again for listening. Note, the views on this podcast represent those of my guest and I.
In the world of pharmacy, we lay the claim. Knowledge and compassion is the golden flame. Science and practice, side by side they groove. In a student's journey, we find the move.
Note: purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support for peer pharmacists in training in educational and intellectual stimulating ways. Again, these are not at all for medical advice or for medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The views in this podcast represent those of my guest, S, and I. Top 300 drugs and their indications. 1 Lortab, hydrocodone/acetaminophen opioid. Pain. 2 Vicodin, hydrocodone/acetaminophen opioid. Pain. 3 Lorcet, hydrocodone/acetaminophen opioid. Pain. 4 Norco, hydrocodone/acetaminophen opioid. Pain. 5 Synthroid, levothyroxine. T4. Hypothyroidism. 6 Levoxyl, levothyroxine T4. Hypothyroidism. 7 Levothyroid, levothyroxine T4. Hypothyroidism. 8 Prinival, lisinopril. ACI. Hypertension/proteinuria. 9 Zestril, lisinopril ACI hypertension/proteinuria. 10 Xanax, alprazolam benzo. Anxiety. 11 Fortamate, metformin biguanide. Diabetes. 12 Glumetza, metformin biguanide. Diabetes. 13 Glucophage, metformin biguanide. Diabetes. 14 Lasix, furosemide loop diuretic hypertension/edema. 15 Prilosec, omeprazole. PPI GERD. 16 Zocor, simvastatin HGM-CoA reductase inhibitor dyslipidemia. 17 Livalo, pitavastatin HGM-CoA reductase inhibitor dyslipidemia. 18 Lescal, fluvastatin, HGM-CoA reductase inhibitor. Dyslipidemia. Take at bedtime. 19 Lipitor, atorvastatin HGM-CoA reductase inhibitor dyslipidemia. 20 Norvasc, amlodipine DHP calcium channel blocker hypertension. 21 Prevental, albuterol short-acting beta agonist rescue inhaler. 22 Ventolin, albuterol, short-acting beta agonist, rescue inhaler. 23 ProAir, albuterol short-acting beta agonist rescue inhaler. 24 Ambien, zolpidem imidazopyridine sleep. 25 Celexa, citalopram, SSRI anxiety/depression. 26 Hydrodiurol, hydrochlorothiazide diuretic. Hypertension. 27 Neurontin, gabapentin, GABA analog. Nerve pain epilepsy. 28 Zantac, ranitidine H2RA. GERD. 29 Ultram, tramadol central acting analgesic pain. 30 Bayers, aspirin. NSAID pain/inflammation/antiplatelet. 31 Ecitrin, aspirin. NSAID. Pain/inflammation/antiplatelet. 32 K-Dur, potassium supplement potassium. Low potassium. 33 Chlorcon, potassium supplement potassium. Low potassium. 34 Clonopin, clonazepam. Benzo. Anxiety/depression. 35 Coumadin, warfarin anticoagulant. 36 Yantoven, warfarin anticoagulant. 37 Singulaire, montelukast. Oral leukotriene receptor antagonist asthma/respiratory/also seasonal allergic rhinitis. 38 low pressure, metoprolol tartrate selective BB. Hypertension/HF. 39 Amrix, cyclobenzaprine muscle relaxant. Muscle relaxer. 40 Flexeril, cyclobenzaprine muscle relaxant. Muscle relaxer. 41 Fexmid, cyclobenzaprine muscle relaxant. Muscle relaxer. 42 Seroquel, quizapine fumarate atypical antipsychotics schizophrenia/bipolar. 43 Plavix, clopidogrel. Antiplatelet. Stroke prevention. 44 Oxycontin, oxycodone opioid. Pain. 45 Deserol, trazodone tetracyclic antidepressant. Labeled for depression but usually sedative off-label. 46 Coreg, carvedilol. 47 Mevacor, lavastidine HMO-CoA reductase inhibitor dyslipidemia. 48 Zoloft, sertraline. SSRI. Anxiety/depression. 49 Cymbalta, duloxetine. SNRI anxiety/depression. 50 Percocet, Roxyset, Endocet, oxycodone/acetaminophen CII opioid. Pain. 51 Advair, fluticasone propionate/salmeterol zinafate bronchodilator. Asthma/COPD. 52 Lantus, insulin glargine, rDNA origin, insulin. Diabetes. 53 Toujeo, insulin glargine, rDNA origin, insulin. Diabetes. 300 units/ml. 54 Simlin, Simlin pen, pramlintide analog of amylin hormone diabetes. Do not give if skip a meal. 55 Toprol XL, metoprolol succinate cardioselective BB. HTN. 56 Zebita, bisoprolol. 57 Zithromax, Zmax, azithromycin macrolide. Bacterial infections. 58 Prozac, floxetine. SSRI. Anxiety/depression. 59 Effexor, venlafaxine. SNRI anxiety/depression/nerve pain. 60 Tenormin, atenolol cardioselective BB-HTN. 61 Eleval, amitriptyline. SNRI. Anxiety/depression/nerve pain. 62 Combivent, ipratropium bromide/albuterol sulfate, MDI, COPD asthma. 63 Wellbutrin, bupropion. Norepinephrine dopamine reuptake inhibitor antidepressant/smoking aid. 64 Zyban, bupropion. Norepinephrine dopamine reuptake inhibitor antidepressant/smoking aid. 65 Nexium, esomeprazole. PPI GERD. 66 Ativan, lorazepam benzo anxiety/panic attacks. 67 Tricor, phenofibrate fibrate dyslipidemia/triglycerides. Take with food cc. 68 Lexapro, escitalopram. SSRI anxiety/depression. 69 Flonase, fluticasone propionate nasal corticosteroid. Nasal congestion. 70 Deltasone, prednisone. Steroid. Inflammation/allergy/immunosuppression. 71 Depakote, D-valproex valproic acid seizure/bipolar. 72 Catapress, clonidine alpha agonist hypertension/sedative/ADHD. 73 Aldamate, methyl-dopa alpha agonist hypertension. 74 Cardizem, diltiazem. CCB. HTN and angina. 75 Karsha, diltiazem. 76 Tiazac, diltiazem. CCB. HTN and angina. 77 Soma, carisoprodol carbamate. Muscle relaxer. 78 Risperdal, risperidone atypical antipsychotic schizophrenia/antipsychotic. 79 Mobic, meloxicam. NSAID anti-inflammatory. 80 Detrol, tolterodine cholinergic incontinence. 81 Topamax, topiramate anticonvulsant seizure/nerve pain. 82 Motrin, ibuprofen. NSAID pain/inflammation. 83 Amoxil, amoxicillin trihydrate penicillin. Bacterial infection. 84 Trimox, amoxicillin trihydrate penicillin. Bacterial infection. 85 Moxitog, amoxicillin trihydrate penicillin. Bacterial infection. 86 Naproxen, naproxen. 87 Zestoretic, lisinopril/hydrochlorothiazide ACE inhibitor and thiazide diuretic. HTN. 88 Prinzide, lisinopril/hydrochlorothiazide ACE inhibitor and thiazide diuretic. HTN. 89 Reglan, metoclopramide. Prokinetic. Nacia/GERD. 90 Bactrim, sulfamethoxazole/trimethoprim sulfur antibiotic. Bacterial infection. 91 Septra, sulfamethoxazole/trimethoprim sulfur antibiotic. Bacterial infection. 92 Actose, pioglitazone. Thiazolidinediens. Diabetes. 93 Abilify, aripiprazole atypical antipsychotic schizophrenia/antipsychotic. 94 Fosamax, alendronate bisphosphonate osteoporosis. 95 Spiriva, Shiotropium bromide inhalation bronchodilator. COPD. 96 Flomax, Tamsulosin. Alpha blocker. BPH. 97 Lyrica, pregabalin anticonvulsant nerve pain. 98 Micronase, glyburide sulfonylurea. Diabetes. 99 Diabeta, glyburide sulfonylurea diabetes. 100 Aricept, dunpazilcholine's teres inhibitor Alzheimer's. 101 Crestor, rosuvastatin HGMO-CoA reductase inhibitor dyslipidemia. 102 Valium, diazepam benzo anxiety/panic attacks. 103 Aldactone, spironolactone potassium sparing diuretic. HFHTN. 104 Inspra, eplerenone potassium sparing diuretic. HFHTN. 105 Bistolich, nebivolol. 106 Texturna, aliskiren and HCDZ. 107 Volturna, aliskiren and valsartan. 108 Protonix, pantoprazole. 109 Lamictal, lamotrigine antiepileptic. Seizure. 110 Copinex, levalbuterol. Laba-asthma/COPD. 111 Glucotrol, Glucotrol XL, glipizide. Sulf diabetes. 112 Allegra, fexofenadine antihistamine. Hives itching allergy. 113 Pravachol, pravastatin. HGMO-CoA reductase. Dyslipidemia. 114 Premarin, estrogens conjugated cream estrogen. Menopause. 115 Imdur, ISMO, isosorbide mononitrate nitrate. Angina HTN. 116 Monokete, isosorbide mononitrate nitrate. Angina HTN. 117 Iserdil, dilatrate, isosorbide dinonitrate nitrate. Angina HTN. 118 Cipro, ciprofloxacin. Fluoroquinolone. Bacterial infection. 119 Diazide, triamterene/hydrochlorothiazide diuretic. HTN. 120 Maxide, triamterene/hydrochlorothiazide diuretic. HTN. 121 Phenergan, promethazine. Antihistamine. Allergies, pain, nausea. 122 Xyloprim, allopurinol xanthine oxidase inhibitors gout. 123 Nitrostat, nitroglycerin nitrates. Angina. 124 Nitroquick, nitroglycerin nitrates. Angina. 125 Prevacid, lansoprazole. PPI GERD. 126 Paxil, paroxetine. SSRI. Anxiety/depression. 127 Pexiva, paroxetine. SSRI anxiety/depression. 128 Vibramycin, doxycycline high-clat-tetracycline antibiotics. Bacterial infection. 129 Vibratabs, doxycycline high-clat-tetracycline antibiotics. Bacterial infection. 130 Adderall, amphetamine/dextroamphetamine salts CII amphetamine. ADHD. 131 Novolog, insulin aspart, rDNA origin. Insulin. Diabetes. 132 Namenda, memantine NMDA receptor blocker Alzheimer's. 133 Duragesic, fentanyl transdermal opioid. Chronic pain. 134 Remeron, mirtazapine. SNRI. Anxiety/depression. 135 Zacia, ezetimibe cholesterol absorption inhibitor dyslipidemia. 136 Celebrex, Celecoxib. NSAID pain/inflammation. 137 Diovan, valsartan angiotensin reductase inhibitor. HTN. 138 Atarax, hydroxyzine HCl, ODC, antihistamine. Sleep, itching allergy anxiety. 139 Unisom, doxylamine antihistamine. Sleep. 140 Inderal, propranolol non-selective BB hypertension/HF. 141 Brevibloc, esmolol. 142 Inopran XL, propranolol non-selective BB hypertension/HF. 143 Lanoxin, digoxin cardiac glycoside arrhythmia and HF. 144 Lanoxicaps, digoxin cardiac glycoside arrhythmia and HF. 145 Digitec, digoxin cardiac glycoside arrhythmia and HF. 146 Drisdol, vitamin D2, ergocalciferol inactive vitamin D. Bone health. 147 Ricotrol, vitamin D3, calcitriol active vitamin D. Bone health. 148 Amaryl, glympyride. Sulfuria. Diabetes. 149 Prandin, repaglinide miglutinidase. Rapid-acting glynidase. 150 Starlix, nateglinide miglutinidase. Rapid-acting glynidase. 151 Vitarin, ezetimibe/simvastatin cholesterol absorption inhibitor and HGMO-CoA cholesterol. 152 Folate, folic acid. Folic acid deficiency/megaloblastic anemia. 153 Folacin, folic acid B vitamin. Folic acid deficiency/megaloblastic anemia. 154 Pteroyl glutamine acid, folic acid B vitamin. Folic acid deficiency/megaloblastic anemia. 155 Keflex, cephalexin monohydrate cef antibiotic. Bacterial infection. 156 Vasotec, enalapril maleate. ACI. HTN. 157 Buspir, buspirone azapirone. Anxiety. 158 Tegretol, carbamazepine antiepileptic. Seizure/nerve pain. 159 Carbatrol, carbamazepine antiepileptic. Seizure/nerve pain. 160 Ecatrol, carbamazepine antiepileptic. Seizure/nerve pain. 161 Cozar, losartan potassium. ARB-HTN. 162 Ritalin, methylene, metadate, methylphenidate phenethylamine and piperidine. ADHD. 163 Ditropan, oxybutynin chloride, oral, antispasmodic. Overactive bladder. 164 Ms Contin, morphine sulfate extended release opioid. Pain. 165 Slow Fe, ferrous sulfate. Iron. Anemia. 166 Lidoderm, lidocaine transdermal amide local anesthetic. Pain for local area. 167 Niferex, iron polysaccharide. Iron. Anemia. 168 Cinemet, carbidopa/levodopa dopaminergic agent. Parkinson's. 169 Duopa, carbidopa/levodopa dopaminergic agent. Enteral suspension. 170 Riteri, carbidopa/levodopa dopaminergic agent. Cap. 171 Stalevo, levodopa/carbidopa and entacapone, Compton. 172 Xanaflex, tizanidine. Centrally acting plus or minus 2 adrenergic agonist. Muscle spasms muscle relaxant. 173 Lyresil, baclofen muscle relaxant. 174 Isoptin, verapamil non-DHP-CCB. HTN, angina. 175 Calin, verapamil non-DHP-CCB HTN, angina. 176 Verolen, verapamil non-DHP-CCB. HTN, angina. 177 Requip, ropinrole dopamine agonist Parkinson's. 178 Scalaxin, metaxalone muscle relaxant. Muscle relaxer, pain. 179 Restoril, temazepam benzo. Anxiety. 180 Bentyl, dicyclamine gut antispasmodic. IBS. 181 Serux, oxazepam benzo. Anxiety. 182 Vistaril, hydroxyzine pamoate antihistamine. Anxiety itching. 183 Dilantin, phenytoin sodium extended anticonvulsant. Seizure. 184 Capsules, phenytoin sodium extended anticonvulsant. Seizure. 185 Diovan HCT, valsartan/hydrochlorothiazide ARB plus thiazide. HTN. 186 Diflucan, fluconazole. Antifungal. 187 Humulin, insulin diabetes. 188 Flovent, fluticasone propionate inhalation steroid and decongestant. 189 Lotrel, amlodipine/benazepril. 190 Xforge, amlodipine/valsartan. CCB/ARB HTN. 191 Azor, amlodipine/olmesartan. CCB/ARB HTN. 192 Phenafen with codeine, acetaminophen/codeine. Pain. 193 Tylenol No. 3, acetaminophen/codeine. Pain. 194 Trileptal, oxcarbazepine anticonvulsant. Seizure. 195 Lithinate, lithium carbonate mood stabilizer. Bipolar disorder. 196 Lithotabs, lithium carbonate mood stabilizer. Bipolar disorder. 197 Lithobid, lithium carbonate mood stabilizer. Bipolar disorder. 198 Mirapex, pramipexole dihydrochloride dopamine agonist. Parkinson's and restless leg. 199 Nistop, Nistadin topical. Antifungal. Fungal infection. 200 Nasonex, Momtasone furoate monohydrate intranasal nasal congestion/allergic rhinitis. 201 Augmentin, amoxicillin/clavulinate potassium bacterial infection. 202 Estrace, estradiol. Menopause. 203 Lotensin, benazepril. ACI. HTN. 204 Tessalin, benzonatate antitussive. Cough. 205 Kenalog, triamcinolone acetonide topical corticosteroid. Itching/rash. 206 Altase, ramipril. ACI. 207 Levaquin, levofloxacin fluoroquinolone. Bacterial infection. 208 Keppra, levetiracetam antiepileptic. Seizure. 209 Giadon, ziprasidone antipsychotic. Always take with food, similar to lurasidone. 210 Latuda, lurasidone antipsychotic. Always take with food, similar to ziprasidone. 211 Fanapt, eloperidone. Antipsychotic. Same QT prolongation risk as ziprasidone. 212 Prolixin, flufenazine first generation antipsychotic. If decanoate is the salt, 2 to 4 weeks. 213 Humalog, insulin lispro, rDNA origin diabetes. 214 Methodos, methadone. Pain/opioid withdrawal. 215 Apidra, insulin glycine diabetes. 216 Lopid, gemfibrozil fibrate cholesterol/triglyceride. Take 3 hours before breakfast and dinner. 217 Benicar, olmesartan midoxamil. 218 Fioricet, butalbital/acetaminophen/caffeine migraine. 219 Medrol, methylprednisolone. Steroid. Inflammation/rash/allergies. 220 Pepsid, famotidine H2 blocker. GERD. 221 Lunsta, esopiclone sedative. Insomnia. 222 Ultracet, tramadol/acetaminophen. Pain. 223 Trexal, methotrexate. Daily for cancer, weekly for RA. 224 Januvia, sitagliptin DPP4 inhibitors diabetes. 225 Cardura, doxazosin. ±1 selective alpha blocker. 226 Javisync, sitagliptin and simvastatin. 227 Janumet, sitagliptin and metformin. 228 Minipress, prazosin. ±1 selective alpha blocker. BPH and HTN. 229 Hitrin, terazosin. ±1 selective alpha blocker. 230 Benicar HCT, olmesartan midoxamil/hydrochlorothiazide ARB and thiazide. HTN. 231 Actinol, risdronate. Bisphosphonate. Osteoporosis. 232 Imitrex, sumatriptan migraine. 233 Lomotil, diphenoxylate/atropine centrally active opioid. Diarrhea. 234 Antivert, Dramamine, meclizine nausea. 235 Cogentin, benztropine Parkinson's. 236 Feldene, piroxicam. NSAID. Anti-inflammatory/pain. 237 Clethodim, clindamycin oral lincosamide. Bacterial infection. 238 Zovirax, acyclovir herpes, shingles chickenpox. 239 Procardia, nifedipine. DHPCCB-HTN. 240, nifedipine, nifedipine. DHPCCB-HTN. 241 Autolat, nifedipine. DHPCCB-HTN. 242 Bumex, bumetanide diuretic HTN. 243 Vesicare, sulfasalazine bladder relaxant overactive bladder. 244 Acupril, quinapril. ACE. HTN. 245 Trivara, trifazole, Inpress, levonorgestrel/ethinyl estradiol contraceptive. 246 Avandia, rosiglitazone. Thiazolidine. Diabetes. 247 Phenergan with codeine, promethazine/codeine cold medicine. Opioid with HH1 antihistamine. 248 Glucovance, glyburide/metformin. Sulfenbiguanide. Diabetes. 249 Novolin 70/30ths, insulin Novolin diabetes. Insulin. 250 metaglip, glipizide/metformin sulf and biguanide. Diabetes. 251 tricycline, tricycline low, trisprintac, trinesa, norgestimate/ethanylistra. Diol contraceptive. 252 zyprexa, olanzapine. Schizophrenia/antipsychotic. 253 yasmin, ocella, drospirenone/ethanyl estradiol birth control. 254 Voltaren, diclofenac sodium oral, can also be gel for pain. NSAID. Anti-inflammatory and pain. 255 Agrenox, dipyridamole/aspirin. Antiplatelet to prevent stroke. 256 Boniva, ibandronate bisphosphonate osteoporosis. 257 Compazine, prochlorperazine phenothiazine class antipsychotic, anti-nausea and anxiety. 258 Compro, prochlorperazine phenothiazine class antipsychotic, anti-nausea and anxiety. 259 Bactroban, mupirocin. Antibiotic for skin infections. 260 Macrodantin, nitrofurantoin and antibiotic for UTI. 261 Furidantin, nitrofurantoin and antibiotic for UTI. 262 Macrobid, nitrofurantoin and antibiotic for UTI. 263 Lotrazone, clotrimazole/betamethasone dipropionate steroid/antifungal. It can treat fungal infections. 264 Flagyl, metronidazole. Antibiotic. 265 Robaxin, methocarbamol muscle relaxant. It can treat muscle spasms and pain. 266 Tussionex, chlorpheniramine/hydrocodone antihistamine/narcotic and narcotic. It can treat cough. 267 Evista, raloxifene. Estrogen modulator. Osteoporosis. 268 Provigil, modafinil stimulant for narcolepsy. 269 Nuvigil, modafinil stimulant for narcolepsy. 270 Carafate, sucralfate antacid. It can treat ulcers. 271 Enablx, darafenicin overactive bladder. 272 Nispan, niacin. Cholesterol medication and vitamin. It can treat high cholesterol and triglyceride levels as well as niacin deficiency. 273 Astelin, azelastine nasal itchy stuffy runny nose. 274 Relafin, nabumetone NSAID, anti-inflammatory, it can treat pain and arthritis. 275 Valtrax, valacyclovir herpes shingles, chicken pox. 276 Armour thyroid, thyroid, Desicat, T3 and T4 hypothyroid. 277 Zofran, ondansetron. Nausea/vomiting. 278 Acefex, rabeprazole. PPI GERD. 279 Sinequin, doxepin. TCA anxiety/depression. 280 Theocron, Theo24, theophylline anhydrous asthma, emphysema COPD. 281 Chantix, varenicline tartrate. Smoking cessation. 282 Dimoptic, timolol maleate ophthalmic non-selective BB. 283 Betopic, betaxolol. Ophthalmic. Selective BB. 284 Ocupress, cartiolol ophthalmic selective BB. 285 Omnicef, cefdinir. Antibiotic. 286 Levemir, insulin detemir diabetes. 287 Pristic, desvenlafaxine antidepressant. 288 Biota, exenatide. GLP-1 agonist. Diabetes. 289 Lavazza, omega-3 acid ethyl esters triglyceride. 290 Mycardis, telmisartan. ARB. HTN. 291 Zalatan, latanoprost glaucoma. 292 stratera, atomoxetine. SNRI ADHD. 293 Vedids, pen-VK, Vicillin, penicillin V potassium. 294 pen-VK, penicillin V potassium. 295 Vicillin, penicillin V potassium. 296 atripla, efavirenz, emtricitabine, tenofovir disoproxyl fumarate. HIV. 297 plaquenil, hydroxychloroquine sulfate. Malaria in third world countries, RA, and lupus in first world. 298 xeroxylin, metolazone thiazide diuretic. 299 thalidone, chlorthalidone thiazide diuretic. 300 proscar, finasteride. BPH. 301 metussin AC, codeine/guaifenesin cough. 302 robitussin AC, codeine/guaifenesin cough. 303 monopril, fosinapril. ACEI. HTN and HF. 304 Prem-Pro, estrogen, conjugated, /medroxyprogesterone acetate estrogen replacement therapy for hot flashes caused by menopause. 305 Patanol, olopatadine ophthalmic. Eye allergic conjunctivitis. 306 Patade, olopatadine ophthalmic eye allergic conjunctivitis. 307 Mavic, Trandolapril. ACIHTN. 308 Viveldot, estradiol topical hormone replacement. 309 Luminol, phenobarbital barabuate. Sedative. 310 Sulfaton, phenobarbital barabuate. Sedative. 311 Vicoprofen, hydrocodone/ibuprofen opioid. Pain. 312 Orthocycline, Sprintac, Norc estimate/ethinyl estradiol contraceptive. 313 Avalide, irbesartan/hydrochlorothiazide. 314 Hizar, losartan/hydrochlorothiazide ARB and HCTC for HTN. 315 Plendil, felodipine. 316 Yaz, drospirenone/ethinyl estradiol contraceptive. 317 Pulmicort, budesonide inhalation steroid. Asthma. 318 Travatin, Travatin Z, travoprost glaucoma. 319 Zezil, levocetirizine. Antihistamine for allergy. 320 Nasacort AQ, triamcinolone acetonide intranasal allergy symptoms. 321 Loestrin FE, microgestin FE, Junal FE, norethindrone/ethinyl estradiol/ferrous fumarate. Contraceptive. 322 Adipex P, phentermine. Appetite suppression for obesity. 323 Ionamine, phentermine appetite suppression for obesity. 324 Cortisone, amiodarone potassium channel blocker antiarrhythmic. 325 Pacerone, amiodarone potassium channel blocker antiarrhythmic. 326 Nizoral, ketoconazole antifungal. 327 Avapro, irbesartan. 328 Pamelor, nortriptyline SNRI for depression. 329 Arimidex, anastrozole estrogen for cancer. 330 Avalox, moxifloxacin fluoroquinolone. 331 Tamiflu, oseltamivir flu vaccine. 332 Viagra, sildenafil citrate. Ed. 333 Apreoline, hydralazine. HTN. 334 Vivance, lisdexamfetamine dimesylate. ADHD. 335 Olfagan P, brimonidine tartrate. Glaucoma also it can treat facial redness caused by rosacea in its topical form. 336 Lidex, fluocinolone topical steroid. It can treat many skin disorders. It can also relieve pain, itching, and swelling of the skin. 337 Nistidine oral, Nistidine oral. This medication is used to treat fungal infections of the mouth. 338 Minicin, minocycline tetracycline antibiotic. 339 Levsin, Levbid, Levsinex, hyoscyamine gut spasmodic for IBS. 340 Levbid, hyoscyamine, gut spasmodic for IBS. 341 Levsinex, hyoscyamine gut spasmodic for IBS. 342 Chalice, tadalafil. 343 Cosopt, dorzolamide/timolol maleate non-selective BB. 344 Pyridium, phenazopyridine. Urinary tract pain. 345 Peridex, chlorhexidine gluconate. Chlorhexidine is an antibacterial used as an antiseptic and for other applications. 346. Periogard, chlorhexidine gluconate. Chlorhexidine is an antibacterial used as an antiseptic and for other applications. 347 Lumigan, Bimetoprost anti-glaucoma. It can reduce pressure inside the eye in its eye drops form. As an eyelash solution, it can help eyelashes grow. 348 Nuvaring, etinogestrol/ethinyl estradiol vaginal. Contraceptive. 349 Prometrium, progesterone oral menopause. 350 Lamisil, terbinafine. Antifungal. 351 Vigamox, moxifloxacin ophthalmic bacterial conjunctivitis. 352 Submicin, tetracycline. Antibiotic. 353 Panmicin, tetracycline antibiotic. 354 Timovate, clobetasol propionate topical steroid itching redness. 355 Provera, medroxyprogesterone acetate contraceptive or endometrial pain. 356 Overal, low/overal, ogestrol, Cris-L, norgestrol with ethinyl estradiol contraceptive. 357 Biaxin, clarithromycin. Macrolide antibiotic. 358 Demedex, torsemide diuretic. Edema or HTN. 359 Indocin, indomethacin NSAID, anti-inflammatory, it can treat pain. 360 Atacand, candesartan Celexetyl ARB for HTN. 361 Allegra D, fexofenadine/pseudoephedrine allergy and congestion. 362 Normadine, labetalol. Non-selective BB. HTN. 363 Trandate, labetalol non-selective BB. HTN. 364 Rest ASIS, cyclosporin emulsion ophthalmic. Immunosuppressive agent used to treat chronic dry eye caused from inflammation. 365 Mycardis HCT, telmisartan/hydrochlorothiazide ARB plus thiazide for HTN. 366 Tenoretic, atenolol with chlorthalidone cardioselective BB plus diuretic. 367 Mycolag 2, nistidine/triamcinolone acetonide fungal skin infection and inflammation caused by it. 368 Desogen, Apri, Orthocept, desogestrol with ethinyl estradiol contraceptive. 369 Orapred, prednisolone sodium phosphate. Inflammation, multiple sclerosis, and arthritis. 370 Zymer, gatafloxacin ophthalmic bacterial conjunctivitis. 371 Levitra, vardenafil. Ed. 372 Staxin, vardenafil. Ed. 373 Suboxone, buprenorphine/naloxone opioid withdrawal. 374 Decadron, dexamethasone oral. Inflammation, allergic reactions, and flare UPS of ulcerative colitis. 375 Veramist, fluticasone furoate nasal allergy, congestion, sneezing, itching. 376 Ciprodex, ciprofloxacin/dexamethasone otic treat outer ear infections. 377 Focalin, dexmethylphenidate. 378 Lotensin HCT, benazepril/hydrochlorothiazide ACE and thiazide for HTN. 379 Elocon, Momtasone Furode topical. Eczema, psoriasis, allergies, and rash. 380 Clarinex, desloratadine antihistamine. It can treat or prevent hives, allergy symptoms. 381 Nolvadex, tamoxifen citrate. 382 Duoneb, ipratropium bromide with albuterol sulfate solution bronchodilator. It can treat COPD. 383 Concerta, methylphenidate. 384 Oxy-IR, oxycodone IR opioid. Pain. 385 Roxicodone, oxycodone IR opioid. Pain. 386 Miralax, polyethylene glycol 3350, NF osmotic laxative. 387 Glycolax, polyethylene glycol 3350, NF osmotic laxative. 388 Zyac, bisoprolol/hydrochlorothiazide selective BB/thiazide diuretic. HTN. 389 Loestrin 24-FE, norethindrone acetate, ethinyl estradiol, ferrous fumarate contraceptive. 390 Colchris, colchicine. 391 Avodart, dutasteride. BPH. 392 Ceftin, cefuroxime-axetyl oral cef-antiobic. 393 Ales, avianide, levonorgestrel with ethinyl estradiol contraceptive. 394 Mercet, Carava, desogestrel with ethinyl estradiol contraceptive. 395 Nikon 135th, Ortho Novum 135th, norethindrone and ethinyl estradiol contraceptive. 396 Prevnar, pneumococcal vaccine. 397 Lupron, Luprolide. GnRH agonist. Prostate cancer. 398 Zolacard, Gosrelin GnRH agonist prostate cancer. 399 Zytiga, abiraterone androgen biosynthesis inhibitors, prostate cancer. 400 Cazadex, bicalutamide first generation anti-androgen prostate cancer. 401 Firmagon, Degarelix GnRH antagonist, prostate cancer. 402 Ranaxa, ranolazine. Add-on therapy for stable angina. Reduce oxygen demand, reduce number of attacks. 403 Nimotop, nimodipine non-DHPCCB hemorrhagic stroke. 404 Cardine, nicardipine. CCB. For hypertensive therapy in ischemic stroke patient, labetalol is other option. 405 Osmitrol, mannitol hemorrhagic stroke. 406 Invokana, canagliflozin SGLT2. Diabetes. 407 Farxiga, dapagliflozin SGLT2. Diabetes. 408 Jardiance, empagliflozin SGLT2. Diabetes. 409 Precose, acarbose alpha glucosidase inhibitor diabetes. No meal, no drugs. 410 Glycet, miglitol. Alpha glucosidase inhibitor. Diabetes. No meal, no drugs. 411 Envirase, Scarinavir mesylate not Scarinavir soft gel capsule. Sources for this episode include WHO publications, drug manuals, medicine handbooks, journals and compendium. Pharmacology, basics. 1. Pharmacology, body of knowledge concerned with the actions of chemicals on biological systems. 2. Medical pharmacology, use of chemicals in prevention, diagnosis and treatment of disease. 3. Toxicology, concerned with undesirable effects of chemicals on biological systems. 4. Pharmacokinetics, what the body does to the drug, absorption, distribution, metabolism, excretion. 5. Pharmacodynamics, what the drug does to the body. 6. Onset of action, how much of drug comes into circulation to produce effect, determined by route of administration and drug dosage. When you increase drug dosage, the concentration of drug in the blood will also increase. 7. Duration of action is affected by drug dosage. Higher the dosage, rate of distribution, rate of metabolism, rate of excretion. 4. Minimum effective concentration, amount of drug required to produce a therapeutic effect. 5. Duration of action, time between the rise to the decline at minimum effective concentration for therapeutic effect. 6. Mechanism of drug action, drug cannot produce any new action in the body, can act on enzymes, ion channels, upregulate or downregulate a system within the body. Effect physiology on the cells but do not produce new actions in body. 15. Ligands, signal molecules. 16. Ra, receptor existing in an active state. 17. Ri, receptor existing in an inactive state. 18. External receptor site, ligand binds outside plasma membrane and produces change inside the cell. 19. Internal receptor site, drug goes inside the cell, binds to receptor inside the cell, moves to nucleus, to produce desired effect. 20. Mechanisms of agonist-mediated activation, ion channels. G protein coupled receptors. Receptor tyrosine kinase. Intracellular hormone receptors. 17. Ion channel, ligand-gated voltage-gated. Second messenger regulated. 1/6. Pharmacology, basics. 18. Ligand-gated ion channel, drug binds to ion channel, activating it to open, sodium enters triggering an action potential. 19. Voltage-gated ion channel, change in charge, potential, between inside the cell and outside the cell causes the channels to open to maintain internal homeostasis. Inside the cell the charge is between -70 MV to -90 MV to open the gate to maintain internal homeostasis. 20. Second messenger regulated, various second messengers that regulate certain channels by opening and closing them. Calcium, CAMP. CAMP cause activation of enzyme which triggers signal transduction pathway. 21. G protein coupled receptors, a signal receptor protein in the plasma membrane that responds to the binding of a signaling molecule by activating a G protein. Also called a G protein linked receptor. 22. Receptor tyrosine kinases. 1. Insulin binds to tyrosine kinase receptor. 2. Tyrosine kinase receptor undergoes autophosphorylation. 3. Insulin receptor is activated. 4. Downstream cascade of signals. 5. Final signal is to recruit glucose transporters, GLUT, move from cytosol to plasma membrane and take glucose into tissues for utilization or storage. 23. 3 amino acid with hydroxyl groups, serine, tyrosine, threonine. 24. Kinase, enzyme that causes phosphorylation. 25. Intracellular hormone receptor, mostly steroids, enter the cell easily because they are lipids, bind to receptors inside the cell in the cytoplasm, get activated, move to nucleus, cause DNA transcription, which leads to the formation of particular proteins. 26. Affinity, measure of tightness in which a drug binds to a receptor. 27. Intrinsic activity, ability of a drug to activate a receptor upon binding. 28. Agonist, a drug that mimics the action of endogenous ligand. 29. Primary agonist, drug binds to the same recognition site as the endogenous agonist. 30. Orthosteric site, primary binding site. 31. Allosteric agonist, bind to a different region on the receptor. 32. Antagonist, drugs that block or reduce the activity of the agonist, have affinity but no intrinsic activity. 33. Syntopic interaction, competition with agonist for the same/overlapping site. 2/6. Pharmacology, basics. 34. Physical antagonist, physically interacts and nullifies the action of the drug X, charcoal, good absorbent, binds to alkaloid to form a complex and will be excreted. 35. Chemical antagonist, Drug forms compounds with other substances like Ca and Mg. X. Tetracycline binds with Ca in milk and then will be eliminated. 36. Physiological antagonist. A drug that counters the effects of another by binding to a different receptor and causing opposing effects. Drug that produces an opposite action by binding to a different receptor. X. Adrenaline is a physiological antagonist to histamine because adrenaline causes bronchodilation and histamine causes bronchoconstriction. 37. Pharmacological antagonist. Drug that binds to receptor and produces no effect, shows no intrinsic activity. 38. Partial agonist. A drug that binds to a receptor and causes a response that is less than that caused by a full agonist. 39. Inverse agonist. In the stomach, histamine receptors are constitutively activated without a stimulus, so under normal conditions they are operating at 20%. Inverse agonist inhibits these receptors, bringing them down to 0%. 40. Competitive agonist. Same binding site as agonist, resembles chemically with agonist, right shift on the dose-response curve, response depends on concentration. 41. Non-competitive agonist. Different binding site of agonist, not resembled chemically, downward shift of DRC, increasing agonist concentration won't make a difference. 42. How do we activate receptor site? 1. Open or close ion channels. 2. Speed up or slow down transporters. 3. Increase or decrease enzyme activity. 43. Efficacy. Maximum effect a drug can produce, can be measured with a graded dose-response curve. 44. Potency. Amount of drug needed to produce a given effect. Determined by affinity of the receptor for the drug. 45. EC50. The dose required for an individual to experience 50% of the maximum effect. 46. ED50. Dose required to produce a therapeutic effect in 50% of the population, median effective dose. 47. Therapeutic index. A ratio that compares the blood concentration at which a drug becomes toxic and the concentration at which the drug is effective. Pharmacology, basics. LD50/ED50. 10:1 Safer drug because it has wider therapeutic index. 3:1 More dangerous drugs, needs more attention because the therapeutic index is narrow. 48. LD50, median lethal dose. 49. Tolerance, reduced response to a drug after prolonged use, develops gradually over a long period of time. X. Alcoholics needs more alcohol on the second day to feel the same effect from the first, liver is accustomed to alcohol so the enzymes are ready. 50. Pharmacokinetic tolerance, enhanced enzymatic breakdown reduces the amount of drug reaching its site of action. X. Barbiturates, carbamazepine, induce their own metabolism, autometabolism, autodestruction, on frequent repeated use. 51. Pharmacodynamic tolerance, tolerance caused by altered nervous system sensitivity, change in receptors. Action of drug is reduced because of downregulation of receptors, meaning that receptor expression or the amount of receptor present will be less, receptor is not as active as before. Or desensitization of receptors, meaning that receptors will not function as well, proteins could go through post-translation modification, meaning that they will lose, for example, a sulfide due to drug use losing their function, some changes are reversible, others are not. And that internalization of receptors, so receptor will not be available. An exhaustion of mediators, depletion of catecholamine, norepinephrine. 52. Natural inherent tolerance, genetic makeup makes an individual resistant or will have more response to a drug. 53. Acquired tolerance, occurs on repeated use of drug. X. Tolerance develops to sedative action of chlorpromazine but not to its anti-seizure action. Pharmacology, basics. Tolerance occurs to sedative action of phenobarbital but not to its anti-epileptic action. 54. Cross-tolerance, development of tolerance to pharmacologically related drugs. X. Partial tolerance between morphine and barbiturates. Complete cross-tolerance between morphine and pethidine, same drug class. 55. Tachyphylaxis, type of tolerance that occurs rapidly within minutes or seconds, only takes a small concentration of drug to cause this. 56 low, narrow, therapeutic index drugs, acetaminophen, theophylline, carbamazepine, digoxin, warfarin, lithium, phenytoin, gentamicin, vancomycin, antidepressants, tricyclic, insulin. 57 high, wide, therapeutic index drugs, NSAIDs benzodiazepines. Most antibiotics furosemide, SSRI. 58 nitroglycerin, can cause tolerance. As pharmacist you must tell the PT they need to have a 10 to 12 nitrate-free period to prevent tolerance. Causes vasodilation. 59 synergism, one drug is going to have an additive effect with another drug, increasing efficacy. Action of one drug is facilitated or increased by another drug. Or when one drug is inactive alone but active when combined with another. 60 additive, effect of two drugs in the same direction X, amlodipine. Pharmacology, basics. 61 amlodipine and atenolol, antihypertensive. Amlodipine is a calcium channel blocker and atenolol is a beta blocker. Both work to reduce hypertension and act on different places in the heart. 62 glibenclamide and metformin, hypoglycemic. Glibenclamide is a sulfonylurea that increases insulin receptor sensitivity and causes secretion of insulin, acts on pancreas. Metformin acts on liver to control blood glucose level. 63 superadditive, potentiation effect of the combination is greater than the individual effects of each component. 64 acetylcholine and physostigmine, acetylcholine acts on muscle to produce effect, physostigmine is inactive. Both are degraded by acetylcholinesterase. When acetylcholine is alone the enzyme will break it down quickly. When you have physostigmine with it the enzyme doesn't know which one to attack, competition between the two, so it increases the duration of acetylcholine. 65 levodopa and carbidopa. Levodopa treats Parkinson's disease by converting to dopamine to prevent movement disorder. When taken orally levodopa is converted to dopamine in the intestine causing adverse effects like nausea, vomiting. Give it with carbidopa which prevents the breakdown in the intestines so that it can be transported to the brain, cross the BBB, where it can be converted to dopamine to act on the basal ganglia. 66 sulfamethoxazole/trimethoprim, inhibits two enzymes in formation of tetrahydrofolic acid which is required for bacterial cell wall synthesis. If you want to kill the bacteria you need sulfamethoxazole to prevent the conversion of PABA to an intermediate product, and then you need trimethoprim to prevent the conversion of the intermediate product to tetrahydrofolic acid. 67 enalapril/hydrochlorothiazide, enalapril, angiotensin converting inhibitor, hydrochlorothiazide, diuretic. Acts on two different places to produce antihypertensive's effect. Drug stems. ANAB for angiogenesis inhibitors, e.g. pazopanib. Anseran. Anseran for serotonin receptor antagonists, especially 5-HT2 antagonists, e.g. ritonseran and mianseran. ANT for various receptors antagonists, e.g. adacaprant and rimonabant. ARIT for anti-arthritic agents, e.g. lobenzerit. ASE for enzymes, e.g. alteplase. Azepam. Azepam or azalam for benzodiazepines, e.g. diazepam and alprazolam. Cane for local anesthetics, e.g. procaine or cocaine. Cane for class I antiarrhythmics, e.g. procainamide. Coxib for COX-2 inhibitors, a type of anti-inflammatory drugs, e.g. celecoxib. MAB for monoclonal antibodies, e.g. infliximab, see nomenclature of monoclonal antibodies. NAB for cannabinoid receptor agonists, e.g. cannabidiol citation needed dronabinol. NABANT for cannabinoid receptor antagonists. NAVER for antiretroviral protease inhibitors, e.g. darunavir. ALOL for beta blockers, e.g. atenolol. PRIL for ACE inhibitors, e.g. captopril. SARTAN for angiotensin II receptor antagonists, e.g. losartan. TYNAB for tyrosine kinase inhibitors, e.g. imatinib. Vastatin for HMG-CoA reductase inhibitors, a group of cholesterol-lowering agents, e.g. simvastatin. Vir for antivirals, e.g. acyclovir or ritonavir. Arte for artemisinin antimalarials, e.g. artemether. Cef for cephalosporins, e.g. cephalexin. Io for iodine-containing radiopharmaceuticals, e.g. iobenguan. Vec for gene therapy vectors, e.g. ilipogene tiparvovec. Marin for messenger RNA products, e.g. tozinamran. Medication errors. What is a medication error? First, an error is an unintended act or an act that does achieve its intended outcome. Medication errors may be defined as any preventable actions that may contribute to the inappropriate or harmful use of a medicine by a patient. Why do medication errors occur? Medication errors may be defined as any preventable action that may contribute to the inappropriate or harmful use of a medicine by a patient. And they may occur due to the lack of focus, and concentration may be due to distractions and interruptions in a busy pharmacy. And they may occur when prescriptions and medication order are not clearly written. And also, they may occur due to the misuse and misinterpretation of abbreviations. What are the 5 rights of safe medication use? 1. The right patient. 2. The right drug. 3. The right time. 4. The right dose. 5. The right route of administration. 6. The right focus on individual performance and overlook crucial system components that contribute to errors. Errors, however, can still occur even after these 5 rights have been verified. What are some system-based causes of medication errors? Some causes of medication errors are the lack of information about the patient, which includes parameters such as age, weight, allergies, diagnoses, pregnancy status, lab values, vital signs. Also, some system-based causes of medication errors are the lack of information about the drug, such as text or computerized references, and communication and teamwork failures. Other system-based causes are unclear, unlabeled, or look-alike drug labels and packages. Moreover, unsafe drug standardization, storage, and distribution, and non-standard, flawed or unsafe medication delivery devices can also cause medication errors. Other causes can include inadequate staff orientation, ongoing education, supervision, and competency validation. Also, inadequate patient education about medication and medication errors. Further, there is a lack of a supportive culture of safety, and also the failure to learn from mistakes. Interpretation of prescriptions and medication orders. 1A prescription is an order for medication issued by a physician, dentist, or other licensed medical practitioner. 2 prescriptions designate a specific medication and dosage to be prepared by a pharmacist and administered to patient. 3 may be presented at the pharmacy by the patient or sent directly to the pharmacy by telephone, fax, or other electronic means, e.g. e-prescriptions. Pharmacist reduces to written form or computer entry. 4 In hospitals and other institutions, a medication order is used. 5 For children include age, weight, and /or body surface area. This may be required to calculate the appropriate dose. Prescriptions and medications orders. For handwritten prescriptions, tamper-resistant prescription pads have been developed. Prevent the unauthorized copying, modification, or counterfeiting of prescriptions. Tamper resistance is achieved through the use of 1. Security paper. 2. Erase-resistant paper. 3. Thermochromatic ink. 4. Embedded holograms. Probable causes of non-compliance. Unclear or misunderstood directions. Undesired side effects that discourage use. Lack of confidence in the drug or the prescriber. Discontinued use due to feeling better or worse. Economic reasons based on the cost of the drug. Absence of patient counseling. Confusion over taking multiple medications. Patient forgot to take medication. Percent compliance rate. Percent compliance rate, number of days supply of drug, over the number of days since Rx refill, multiplied by 100. There are levels of organization. From atom to molecule or compound to organelle to cell to tissue to organ system. Chemical level refers to the atoms, molecules, and macromolecules which form nucleic acids, proteins, carbohydrates, and lipids. Cellular level refers to the atoms, molecules, macromolecules, which form the functional and structural unit of life, and basic and specialized functions. For the tissue level of organization, tissue level cells of similar shape and specialized function. There are 4 major tissue types. 1 muscle specialized for contracting and generating tension. 2 nervous specialized in impulse production and transmission. 3 connective specialized in connecting and supporting. 4 epithelial specialized in surface lining and exchange. Organs level and organ system level. The organ level is composed of 2 or more tissues that perform a common function. The organ system level is composed of 2 or more organs that work to perform a common function that is essential to survival, and these include the digestive, respiratory, cardiovascular, and the human body contains 11 systems. The organism, this is a collection of body systems working together to maintain life. The parts of an organism strive to maintain an internal balance, and this includes homeostasis. Levels of structural organization. 1. Circulatory system: heart, blood, and blood vessels. Digestive system: mouth, pharynx, esophagus, stomach, small intestine, large intestine, salivary glands, exocrine pancreas, liver, and gallbladder. Respiratory system: nose, pharynx, larynx, trachea, bronchi, and lungs. Urinary system: kidneys, ureters, urinary bladder, and urethra. Skeletal system: bones, cartilage, and joints. Muscular system: skeletal muscles. Integumentary system: skin, hair, nails. Immune system: lymph nodes, thymus, bone marrow, tonsils, and adenoids. Nervous system: brain, spinal cord, peripheral nerves, and special sense organs. Homeostasis: the maintenance of a stable internal environment. 37 degrees Celsius, pH 7.3 to 7.4. The internal environment is made of the extracellular fluid or ECF. Homeostatic control systems: network of body components that operate to maintain a given factor in the internal environment relatively constant around an optimum level. These include local intrinsic controls which are inherent, or built into a particular organ. There are also systemic, extrinsic, controls outside of an organ, involves neural and endocrine regulation, and coordinate various organs and systems. Negative feedback loops. Negative feedback loops operate by maintaining homeostasis by detecting a deviation from a set point and acting to restore that set point. 4 components of a negative feedback loop. 1 controlled variable. 2 sensor. 3 control center. 4 effector. All the feedback mechanisms that maintain homeostasis use negative feedback. Stimulus to sensor to control to the effector. Other regulatory mechanisms. There are also positive feedback loops. 1 in positive feedback loops, they continue increasing a change. 2 in positive feedback loops, the controlled variable moves in one direction. An example of positive feedback loops is uterine contractions. Steps. 1 nerve impulses from the cervix are transmitted to the brain. 2 the brain stimulates the pituitary gland to secrete oxytocin. 3 the oxytocin is carried in the bloodstream to the uterus. 4 the oxytocin stimulates uterine contractions and pushes the baby toward the cervix. 5 the head of the baby pushes against the cervix. There is also feed-forward mechanisms. Feed-forward mechanisms anticipate change and respond to that change before it happens and maintains stability. Examples of this are watering of mouth, salivation, as a result of sight, smell, or thought of food. Also, there is a rise in respiration before exercise, as well as the increased secretion of insulin as a result of food in the digestive tract, and this avoids excessive rise of glucose in blood after the meal. There is also homeostasis. Homeostasis is a condition of equilibrium, balance, in the body's internal environment. Homeostasis helps the body maintain an almost constant internal environment. This is tied to a dynamic condition, and there is a narrow range which is compatible with maintaining life. For example, blood glucose levels range between 70 to 110 mg of glucose/dl of blood. Moreover, the whole body contributes to maintaining the internal environment within normal limits. Additionally, there is homeostatic balance. However, homeostasis can be disrupted, due to physical insults such as intense heat or lack of oxygen. Additionally, changes in the internal environment such as the drop in blood glucose due to the lack of food. Also, there is physiological stress such as the demands of work or school. Furthermore, there are disruptions which can be mild and temporary in which balance is quickly restored. However, they can be intense and prolonged which involve poisoning or severe infections. Homeostatic and body fluids. Homeostasis also involves maintaining the volume and composition of body fluids which are important. Body fluids are defined as dilute, watery solutions containing dissolved chemicals inside or outside of the cell. There is also intracellular fluid, which is the fluid within cells. Furthermore, there is extracellular fluid, which is the fluid outside cells, and this also includes the interstitial fluid which includes the extracellular fluid between cells and tissues. We can also view the body as an open system, which exchanges materials and energy with its surroundings. Further, in terms of the percentage of water for a newborn infant, it is made of 80% water, an adult male is made of 60% water, and an adult female is made of 50% water. Elderly people can be made of about 45% water. Also, it is worth noting that the extracellular fluid includes the plasma, the interstitial fluid and the transcellular fluid which is located in specific anatomical areas. The transcellular fluid includes the CSF, the intraocular fluid, the pleural fluid, the peritoneal fluid, the synovial fluid and the digestive secretions. It is also worth noting that solutes involve dissolved particles. Electrolytes are charged particles inclusive of cations which are positively charged ions such as sodium cations and potassium cations. Anions which are negatively charged ions such as chloride ions, and bicarbonate ions. Additionally, non-electrolytes are uncharged such as proteins, urea, glucose, oxygen, and carbon dioxide. In terms of sodium concentration and potassium concentration, sodium is around the same in the plasma and interstitial fluid, however it is around 10 in skeletal muscle. However, for potassium, the ion concentrations in the plasma and interstitial fluid is rather small, however the concentration inside the skeletal muscle is large. Intra-ECF water redistribution. Plasma versus interstitium. This includes the balance of Starling forces acting across the capillary membrane. 1. Osmotic force. 2. Hydrostatic force. The balance between hydrostatic and colloid osmotic forces across the capillary membranes. There is also the intracellular versus the extracellular, which involves looking at the osmotic effect, e.g. electrolytes. It is important to note that plasma osmolarity measure ECF osmolarity. This is good since plasma is clinically accessible, and dominated by sodium ion concentration and the associated anions. Also, under normal conditions, ECF osmolarity can be roughly estimated as P_osm equals 2 times the concentration of sodium in the plasma, which is 270 to 290 milliosmolar. The ECF vs ICF. The extracellular fluid contains large amounts of sodium, chloride, and bicarbonate ion. Nutrients for the cells, such as oxygen, glucose, fatty acids, and amino acids. It also contains carbon dioxide that is being transported from the cells to the lungs to be excreted. Additionally, other cellular waste products are being transported to the kidneys for excretion. Furthermore, the intracellular fluid contains 1. Large amounts of potassium, 2. Magnesium, 3. Phosphate ions instead of the sodium and chloride ions found in the extracellular fluid. The intracellular fluid contains special mechanisms for transporting ions through the cell membranes, which maintain the ion concentration differences between the extracellular and intracellular fluids. Homeostasis involves several types of regulation. There is thermoregulation, osmoregulation, and glucoregulation. The organs of homeostasis are the brain, muscles, skin, lungs, pancreas, and kidneys. Why control temperature? Environmental temperature is constantly changing. However, the body must be kept at a constant temperature of 37 degrees Celsius. This is the optimum temperature for the body's enzymes. Even the slight changes in body temperature can have a life-threatening effects on health. If body temperature falls too low, reactions become too slow for cells to survive too high, and the body's enzymes are at risk of denaturing. Some important properties of carrier proteins are that they are stereoselective, there can be channel saturation which in diabetes is uncontrolled, and there can be competition. Channel saturation, in simple diffusion, increases proportionally with concentration of substance. Classes of antineoplastic agents include G2 inhibitors, M inhibitors, G1 inhibitors, and S inhibitors. G2 involves double-checking the DNA. M or mitosis involves cell splitting. G1 involves the cell contents being duplicated and S involves the DNA synthesis. G2 inhibitors are etoposide, tenofovir, irinotecan, topotecan. S inhibitors are azathioprine, cladribine, cytarabine, 5-fluorouracil, 6-mercaptopurine, hydroxyurea, and methotrexate. Also, M inhibitors include vincristine, vinblastine, paclitaxel, and eribulin. Also, G1 inhibitors include cisplatin, busulfan, cyclophosphamide, and nitrosoureas. Antineoplastics agents. The international non-proprietary name or official generic name will be followed by the route of administration, which will be followed by the mechanism of action. After which we will read the indications and the major toxicities. The first group of antineoplastic agents includes 1. Cytotoxic antineoplastics. The first subgroup of this group is 1. Nucleoside analogues. 1. Azacitidine. The route of administration can be subcutaneous or intravenous. The mechanism of action involves azacitidine acting as a DNA methyltransferase inhibitor and azacitidine incorporates itself into RNA, hence inhibiting gene expression. The indications for azacitidine include myelodysplastic syndromes, acute myeloid leukemia and chronic myeloid leukemia. Additionally, the major toxicities include myelosuppression, kidney failure, uncommon/rare, renal tubular acidosis and hypokalemia. Reference: NIH website www.ncbi.nlm.nih.gov/books/NBK548022. Antineoplastic agents. Alkylating agents. O-altritamine, bendamustine, busulfan, carmustine, chlorambucil, cyclophosphamide, dacarbazine, ifosfamide, lomustine, lurbinectidine, mechlorethamine, melphalan, procarbazine, streptozicin, temozolomide, thiotepa, trabectedin. O-platinum coordination complexes. Carboplatin, cisplatin, oxaliplatin. Antibiotics, cytotoxic. O-bleomycin, dactinomycin, daunorubicin, doxorubicin, epirubicin, idarubicin, mitomycin, mitoxantrone, plicamycin, valrubicin. Antimetabolites. O-antifolates, methotrexate, pemetrexed, pralatrexate, trimetrexate. O-purine analogues, azathioprine, cladribine, fludarabine, mercaptopurine, thioguanine. O-pyrimidine analogues, azacitidine, capecitabine, cytarabine, decitabine, floxuridine, fluorouracil, gemcitabine, trifluoridine/tipiracil. Biologic response modifiers. O-aldesleukin, IL-2, denileukin diftitox, interferon gamma. Histone deacetylase inhibitors. O-belinostat, panobinostat, romidepsin, vorinostat. Hormonal agents. O-antiandrogens, abiraterone, apalutamide, bicalutamide, cyproterone, enzalutamide, flutamide, nilutamide. O antiestrogens, including aromatase inhibitors anastrozole, exemestane, fulvestrant, letrozole, raloxifene, tamoxifen, toremifene. O gonadotropin-releasing hormone analogues, digorilix, gosrelin, hystrelin, luprolide, rilugolix, triptorelin. O peptide hormones, lanreotide, octreotide, pasireotide. Monoclonal antibodies. O alemtuzumab, atezolizumab, avelumab, bevacizumab, blinatumomab, brentuximab, semiplimab, caduximab, daratumumab, dinutuximab, dostarlimab, durvalumab, elotuzumab, gemtuzumab, enotuzumab ozogamicin, ipilimumab, megamulizumab, moxetumomab pseudotox, nicitumumab, nivolumab, ofatumumab, olaratumab, panitumumab, pembrolizumab, pertuzumab, ramucirumab, rituximab, teclistamab, tositumumab, trastuzumab, tremelimumab. Protein kinase inhibitors. O abemaciclib, acalabrutinib, afatinib, alectinib, alpelisib, axitinib, binimetinib, bortezomib, bosutinib, brigatinib, cabozantinib, carfilzomib, siratinib, cobimetinib, copanlisib, crizotinib, dabrafenib, dacomitinib, dasatinib, duvlazib, inazatinib, encorafenib, ontrectinib, erdafitinib, erlotinib, fedratinib, futibatinib, gafatinib, gilteritinib, glasdegib, ibrutinib, idlaisib, imatinib, infigratinib, ivosidenib, ixazimib, lopatinib, larotrectinib, lenvatinib, lorlatinib, midostaurin. Naratinib, nilotinib, niraparib, olaparib, osimertinib, palbociclib, pazopanib, pemigatinib, pexidartinib, ponatinib, regorafenib, ribocicib, rucaparib, ruxultinib, selametinib, sinidegib, sorafenib, sunitinib, talazoparib, trametinib, vanditanib, vemurafenib, vismidegib, zonubrutinib. Taxanes. Ocabazitaxel, docetaxel, paclitaxel. Topoisomerase inhibitors. O-adiposide, irinotecan, tenopozid, topotecan. Vinca alkaloids. Ovinblastine, vincristine, vinorelbine. Moving right along with the next section. Action potential. Resting membrane potential. It is the voltage difference existing across the cell at rest. This exists in all cells. RMP, -70 to 90 MV. RMP is contributed by Na/K-ADPase, 0. Membrane potential. The potential difference between inside and outside the membrane. Due to different concentrations of ions, such as sodium, Na+, high outside, and potassium and large protein molecules inside. Na and ions create positivity outside and inside the cell. 1. Resting membrane potential, voltage difference across the cell membrane at rest, typically -70 to -90 MV. 2. Why is the resting membrane potential -70 MV? 1. Na+/K and ADPase channel pumps 3 Na and out and 2 K and in, making the internal charge more negative to -5 MV. 2. K and will leave the cell through leaky K channels, making the charge to -90 MV. 3. Leaky Na and channels will pump Na and back into the cell, making the charge -70 MV. 4. K and goes back inside to go back to -90 MV. 3. Nernst potential, equilibrium between the K and voltage inside and outside the cell. 4. Depolarization, excitatory posts neoptic potential. Glutamate binds to ligand-gated channel to bring in large amount of Na and Ca and bringing the charge to -55 MV. 5. Hyperpolarization, inhibitory posts inhibitic potential. GABA binds to ligand-gated channel to bring in Cl, bringing the charge to -90 MV. 6. Temporal summation, 1 neuron, multiple signals. 7. Spatial summation, multiple neurons firing different signals. 8. Action potential, 1. NA and voltage-gated channels open at -55 MV and close at 30 MV2. When 30 MV is reached, the K and voltage-gated channels will open and K and will leave, bringing the charge to -90 MV. K and is attached to proteins and anions. Simultaneously, Ca and tells the vesicles to release acetylcholine via exocytosis. 9 absolute refractory period, depolarization and repolarization. 10 relative refractory period, hyperpolarization. Routes of administration guide. IT intrathecal in the spine. 4 intravenous. IM intramuscularly. PO by mouth. Topical referring to applying to a specific place on the body such as skin or mucous membranes. Note, purpose of these episodes not at all, for advice or medical suggestions. These are aimed to provide support for peer pharmacists in training in educational and intellectual stimulating ways. Again, these are not at all for medical advice, or for medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The views in this podcast represent those of my guest, S, and I.
It has begun with the CYP450 Metabolism Fun 1A1, you just won, with the detoxification and aromatic hydrocarbon enzymatic hydroxylation 1A2, this is cool. Detoxification is its mode again with the oxidation of arylamine, nitrosamine, and caffeine. The facts on the scene, and I hear some people have farms of oxen. 1A2 can bioactivate aflatoxin. 2C9 and 2C19 the metabolism of narrow therapeutic window on the scene. 3A4/5 most honorable, most popular UC. Detoxification, andalkylation and especially with morphine and normorphine. 50% of the drug's reactions metabolism on the scene. 2E1, with its preference for haloalkanes. 1B1, we don't want any consternation, this functions to cause bioactivation, not good UC. Let's look at 2D6, with its andalkylation, oh yeah hydroxylation, and yeah dalkylation. These are just some of the CYPs you see. It's an enzyme in phase 1 of first pass. With its polymorphism, families, and subclass.
Okay, this is another addendum to the episodes entitled The Journey to NAPLEX Success. This is another addendum. We're going to be talking about agonists and antagonists and all the different flavors. So agonists are drugs that bind to a cell's receptor in order to mimic the effect of a substance the body naturally produces that binds to the same receptor. Two main classes of receptor ligands in pharmacology. You have agonists and antagonists, and the references for this episode will be listed in the episode description. So agonists tend to be smaller molecules that affect the activation of receptors. Note, this may result in stimulation or inhibition of the cell and organ function. Full agonists produce maximal biological response. Full agonists produce maximal biological response. Has maximal positive intrinsic activity, aka efficacy. Partial agonists, whereas partial agonists produce partial maximal biological response as compared to full agonists. So partial agonists produce partial maximal biological response. Partial agonists have lower positive intrinsic activity, and they may competitively inhibit full agonists, preventing maximal biological response. So let's run through that again. Full agonists produce maximal biological response. It has maximal positive intrinsic activity, so efficacy. And partial agonists produce partial maximal biological response as compared to full agonists. They have lower positive intrinsic activity, and they may competitively inhibit full agonists, preventing maximal biological response. If the partial agonist is bound to a receptor, the full agonist typically cannot bind. Why use a partial agonist? Full agonists may cause too much activation, resulting in toxicity or receptor adaptation or prolonged use, like desensitization and downregulation. The lower efficacy of partial agonists minimizes these complications. Now you also have inverse agonists. These produce opposite biological response to that of the endogenous agonist. Has negative intrinsic activity. So let's talk about antagonists. Antagonists tend to be larger molecules producing inhibitory effects. Inhibitory effect. There are antagonists that act at the receptor, also known as receptor antagonists. So let's make sure we keep this thing in focus. So antagonists, by definition, have zero intrinsic activity. Antagonists, by definition, have zero intrinsic activity. Full agonists have intrinsic activity of 100%. Maximum biological response. Partial agonists have intrinsic activity greater than 0 but less than 100. Partial agonists can competitively inhibit a full agonist. You also have inverse agonists, so you have intrinsic activity less than 0. And then you also have non-competitive antagonists, and those can be unsurmountable, depending on them being irreversible, steric. We will get to that. So let's keep going. Just a quick note: efficacy is referring to different levels of biological response or intracellular signaling when they occupy the same receptor. Intrinsic activity refers to the maximal possible effect that can be produced by a drug. Intrinsic activity is determined by the drug-receptor relationship for a drug that acts on the receptor. Okay, you also have efficacy. You also have affinity, which is the measure of the ability of the drug to bind to its molecular target. So the affinity is a measure of the ability of the drug to bind to its molecular target. The VC50, which is a measure of the potency of the drug. So let's keep going. Antagonists. They tend to be larger molecules exhibiting inhibitory effects. There are antagonists that act at the receptor. These are known as receptor antagonists. Antagonists do not have intrinsic activity. They simply block the agonists from binding. So if we think about these things on a spectrum, we think about efficacy related to the endogenous ligand. You have your full inverse agonist at less than 0, your partial inverse agonist still less than 0. You have your antagonist at 0, and you have your partial agonist, which is greater than 0 and less than 100. We're talking about intrinsic activity, and then you have your full agonist at 100%. Okay, intrinsic activity, positive intrinsic activity. So competitive antagonists, reversible or surmountable, binds to a receptor at the same site as the endogenous or pharmacological agonist, blocking agonist binding and therefore receptor activation. So it binds to a receptor at the same site as the endogenous or pharmacological agonist, blocking agonist binding and therefore receptor activation. Okay, so if you were to look at the plot of an agonist versus agonist effect, when you include the competitive antagonist, it shifts to the right. These are ideal scenarios, of course. Okay, antagonism can be reversed by increasing the amount or dose of agonists. Thus, we have the surmountability. This is talking about competitive antagonists. So competitive antagonists do not affect agonist efficacy. They do decrease affinity and potency. So competitive antagonists do not affect agonist efficacy. They do decrease affinity and potency. Competitive antagonists have affinity or potency for the receptor, but not intrinsic activity. By definition, an antagonist does not have intrinsic activity. Receptors can interact with agonists or the competitive antagonists. Okay. And that is exclusive. Okay, non-competitive receptor antagonists. Non-competitive receptor antagonists. Non-competitive receptor antagonists, unsurmountable. So irreversible binds to the same site as the agonist, not easily displaced, generally irreversible due to the covalent bonds between the antagonist and the receptor, reducing the number of receptors available to the agonist. So just a quick aside, picture a graph of an agonist versus a biological response, with your minimum toxic concentration referenced and noted, and your minimum effective concentration referenced and noted. So let's just think about that. Think about that. And you have your MEC below and your MTC above. So MTC, minimum toxic concentration, minimum effective concentration. This is just picture this graph with these points noted on it. Okay. So with the full agonist and partial agonist starting at the same XY point, ideally, the partial agonist will plateau between the MTC and MEC. The minimum toxic concentration and minimum effective concentration, whereas the full agonist will have a higher biological response and plateau higher. Okay, let's keep going. In the absence of spare receptors, the dose response curve will show lower maximum when the agonist is combined with a non-competitive antagonist. However, in the presence of spare receptors, there's gradually or gradated upon increasing non-competitive antagonists, a decrease in agonist effect. So, however, in the presence of spare receptors, there is gradually or gradated upon increasing non-competitive antagonists, a decrease in agonist effect. So, allosteric non-competitive antagonists. So, allosteric is referring to the other side, and orthosterics is referring to the right binding site. So, binding to the allosteric site modifies the conformation of the primary site, with negative allosteric antagonists resulting in an altered conformation that's less responsive to the agonist. So let's wrap this up. Physiological antagonists, molecules that do not bind the same receptor and as the endogenous ligand, but produce an effect opposite to the agonist effect. Molecules that do not bind the same receptor of the endogenous ligand, but produce an effect opposite to the agonist effect. So this is the physiological antagonist. Now a chemical antagonist, as we conclude. Drugs do not interact with agonist receptor, but rather reduce the concentration of the agonist by forming a chemical complex. Let's go through that again. Physiological antagonists, molecules that do not bind the same receptor of the endogenous ligand, but produce an effect. Opposite to the agonist effect. Chemical antagonists, drugs do not interact with agonist receptor, but rather reduce the concentration of an agonist by forming a chemical complex. So hopefully this helped. These are important terms. It's important to know these things. These are like in a way, these are very important. Very, very important. So all the best. Take care. This is the conclusion of this addendum.
DP, NAPLEX, it's dependent on K. The oil to wire partition coefficient of the drug, as well as on and in brackets C1 minus C2. Rum patum tum. Ionization of a weak electrolyte. You know, I always wanted to be an acolyte, a thurifer, a catechist, or a trumpeter, you see. But today we're talking about my good friend, the trumpeter, but less chatelier in the ionization. So ionization is affected by pH of the medium in which the drug is dissolved. as well as by the pKa. Remember, non-ionized are like the chemical thugs, more liquid, soluble, the diffusive thug, if you will. They are more lipid-soluble than the ionized and partitions more readily. Hopefully by now you realize. Rubber tum tum, let's have a drum roll. Here, little beggar boy, oh, that's for the periodic table. Let's talk about the transport process that's not a stable. The octane transport transport of the drug, with it moving across a concentration gradient, requiring energy, selective potentially, saturation possibility, and competitive it can be. Yet we must look across the whole and see that facilitated diffusion is on the carrier-mediated transport system wards. Facilitated diffusion occurs across a concentration gradient and does not require energy. Obrigada, e você, como você está? Tudo bem, tudo. Wow, fala pequeño português. So let's talk in English, por favor. S'il vous plaît. With that paracellular transport, drug transport across tight, narrow junctions between cells or trans-endothelial channels. No, I'm not talking about fire stick, but let me give you a conceptual trick. Paracellular transport involves both diffusion, unconvective or bulk fill of water, and the accompanying water-soluble drugs to the channels. That can be a hint. Now let's look at the vesicles, newly minted idea in this lyrical scheme. Vesicular transport is the process of engulfing particles or dissolved materials by a cell. Engulfed. Pino with drinking. Fado with eating. Pinocytosis, engulfment of small solute or fluid volumes. Phagocytosis is engulfment of larger particles. Your macromolecules, generally by macrophages. Endocytosis and exocytosis are the movement of macromolecules into and out of the cell. Biopharmaceutics and drug delivery this guns. So we've reached the end of this lyrical scheme. You see? We'll pick back up conceptually in episode 2B. Okay, so grateful and humble to be pursuing further study as a pharmacist in the US. These episodes again will be under the theme, The Journey to NAPLEX Success. These will cover in summative form key points that stand out to me as I embark on my journey as a pharmacy student and chart a course to NAPLEX Success. Note the purpose of these episodes, not at all for advice or medical suggestions, but to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Not at all for medical advice or medical suggestions. Please see a local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The newcomer becomes a pharmacist in training. The journey to NAPLEX success. The North American Pharmacist Licensure Examination, NAPLEX, is a standard examination created by the National Association of Boards of Pharmacy, NABP, to help individual state boards of pharmacy assess an individual's competency and knowledge so they may be given a license to practice. So this is an important exam. So be abbreviations you want to keep in mind as we conclude. UNSP 34, United States Pharmacopoeia 34, and NF Natural Formulary 29. So, this is the end of the episode. Thanks for listening.
Grateful and humble to be pursuing further studies as a pharmacist in training in the US. These episodes will be under the theme, The Journey to NAPLEX Success. These will cover, in summative form, key points that stand out to me as I embark on my journey as a pharmacy student and chart a course in NAPLEX Success. Note the purpose of these episodes. These are not at all for advice or medical suggestions, but to provide support for peer pharmacists in training in educational and intellectually stimulating ways. These are not at all for medical advice or for medical suggestions. Please see a local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The new chemist becomes a pharmacist in training, the journey to NAPLEX success. So the NAPLEX, the North American Pharmacist Licensure Examination, is a standard examination created by the National Association of Boards of Pharmacy, NABP, to help individual state boards of pharmacy assess an individual's competency and knowledge so that they may be given a license to practice. Some big abbreviations you want to keep in mind: USP, United States Pharmacopoeia 34, and Natural Formulary, NF 29. So this would be episode 2A. So there will be a 2B and there will be a 2C. So this is 2A. Episode 2A. So biopharmaceutics and drug delivery systems. So some key ideas we want to keep in mind. Biopharmaceutics is a study of the relation of the physical and chemical properties of a drug to its bioavailability, pharmacokinetics, and pharmacodynamics and toxicological effects. Key terms in review: your drug product. It is the finished dosage form, example tablet capsule solution, that contains the active drug ingredient in association with non-drug, usually inactive ingredients, excipients that make up the vehicle or formulation matrix. Drug delivery system is a more complete concept, which includes the drug formulation and the dynamic interaction among the drug, its formulation matrix, its container, and the patient. Bioavailability is a measurement of the rate and extent or amount of systemic absorption of the therapeutically active drug. Pharmacokinetics is the study of the body's effect on the drug, ADME. Pharmacodynamics is the study of the drug's effect on the body. So, how we're going to do this episode is going to be completely lyrical. So we're going to begin the lyrical portion right now. Biopharmaceutics and drug delivery systems. Biopharmaceutics is like a Rubik's Cube, with your 4 ideas making you drool. Bioavailability is a measurement of the rate and extent or amount of systemic absorption. Please take the right portion. The systemic absorption of the therapeutically active drug. Yeah. Biopharmaceutics includes pharmacokinetics. Your A, your D, your M, your E. The effect of the body on the drug with that A absorption, D distribution, M metabolism, and excretion. Biopharmaceutics includes pharmacodynamics with the effects of the drug on the man. We are looking at the relation between drug concentration at the site of the action, its response, which is the main caption. Woo! Then we also consider in biopharmaceutics the toxicologic effects. Lest I forget, the drug product in its formulation matrix or vehicle with the active ingredient and excipients. Lest I forget, the drug delivery with the dynamic menagerie of interactions among the drug, its formulation matrix, its container, and the patient. Continuing on with the spiel, let's drive the drug transport and absorption wheel. Across the cell membrane, the drug molecules enter the bloodstream and are transported to the tissues and organs. Let's look at some key processes in absorption. Transcellular passive, diffusion and partitioning, paracellular transport, diffusion and convection. Let me add some vocal inflections with your carrier mediated transport and the P glycoprotein mediated efflux, which we'll get to in episode 2b. These general principles are important, you see. These general principles are important to know. These general principles are important so assimilable. Compose P, passive diffusion. In thugs, they traverse the cell membrane easily than your ionic soluble drugs. We cannot forget the LMWs, the low molecular weight, just like the chemical thugs, across a cell membrane more easily than the high molecular weight drugs. Let's keep it going. Do you hear what I say? We will progress in pharmacy. HU, you know. Passive diffusion and partitioning within the cytoplasm, or the fluid that's interstitial. Your drugs under transport. This is not pontificial, it's simple. The simple diffusion with a great fixed law. Simple passive diffusion involves the transfer of drugs from an area of high concentration C1 to an area of low concentration C2. According to Fick's law, dq over dt equals ideally dA over H in brackets C1 minus C2, where dq over dt is the rate of drug diffusion. You see, D is the diffusion coefficient for the drug. A is the surface area of the plane across which transfer occurs. Remember your chemistry thugs. H is the thickness of the region through which diffusion occurs, and C1 minus C2 is the difference between the drug concentration in area 1 and area 2 respectively. So with the passive drug transport, welcome to my conceptual court. It involves successive partitioning of a solute between aqueous and lipid phases, as well as diffusion within respective phases. Modifying Fick's law, please. Let's applaud. I'm kidding, but we do this to accommodate partitioning of drug. dq over dt equals d times A times K over H in brackets C1 minus C2, where hold it, the rate of drug diffusion dq over dt now reflects its dependence on K, the oil to water partition coefficient of the drug, as well as on A, and in brackets C1 minus C2. Rum pa tum tum. Ionization of a weak electrolyte. You know, I always wanted to be an acolyte, a thurifer, a catechist, or a trumpeter, you see, but today we're talking about my good friend, not the trumpeter, but le chatelier, in the ionization. So ionization is affected by pH of the medium in which the drug is dissolved, as well as by the pKa. Remember, non-ionized are like the chemical thugs, more lipid soluble, the diffusive plug, if you will. They are more lipid soluble than the ionized, and it partitions more readily. Hopefully by now you realize. Rumpa tum tum, let's have a drum roll. Here, little beggar boy. Oh, that's 4. The periodic table. Let's talk about the transport process that's not a fable. The active transport of the drug, with it moving across a concentration gradient, requiring energy, selective potentially, saturation possibility, and competitive it can be. Yet we must look across the hall and see that facilitated diffusion is on the carrier-mediated transport system walls. Facilitated diffusion occurs across a concentration gradient and does not require energy. Obrigada, e você? Como você está? Tudo bem? Tudo bem? Tudo. Wow, fala pequeño português. So let's talk in English, por favor. S'il vous plaît. With that paracellular transport, drug transport across tight, narrow junctions between cells or trans-endothelial channels. No, I'm not talking about fire stick, but let me give you a conceptual trick. Paracellular transport involves both diffusion and convective or bulk flow of water and the accompanying water-soluble drugs to the channels. That can be a hint. Now let's look at the vesicles. Newly minted idea in this lyrical scheme. Vesicular transport is the process of engulfing particles or dissolved materials by a cell. Engulfment. Pinot, we're drinking. Fago, we're eating. Pinocytosis, engulfment of small solute or fluid volumes. Phagocytosis is the engulfment of larger particles, your macromolecules, generally by macrophages. Endocytosis and exocytosis are the movement of macromolecules into and out of the cell. Biopharmaceutics and drug delivery systems. So we've reached the end of this lyrical scheme. You see, but we'll pick back up conceptually in episode 2B. Okay, so grateful and humbled to be pursuing further studies as a pharmacist in the US. These episodes again will be under the theme, The Journey to NAPLEX Success. These will cover in summative form key points that stand out to me as I embark on my journey as a pharmacy student and chart a course to NAPLEX Success. Note, the purpose of these episodes, not at all for advice or medical suggestions, but to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Not at all for medical advice or medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The newcomer becomes a pharmacist in training, the journey to NAPLEX success. The North American Pharmacist Licensure Examination, NAPLEX, is a standard examination created by the National Association of Boards of Pharmacy, NABP, to help individual state boards of pharmacy assess an individual's competency and knowledge so that they may be given a license to practice. So this is an important exam. So big abbreviations we want to keep in mind as we conclude. USP 34, United States Pharmacopoeia 34, and NF Natural Formulary 29. So this is the end of the episode. Thanks for listening.
What is the brand name of Avacavir, dolutegravir, lamivudine, Triumec? 2. What is the generic name of Triumec, Avacavir, dolutegravir, lamivudine? 3. What are the indications of Triumec, generic name, Avacavir, dolutegravir, lamivudine, indicated for the treatment of HIV-1 infection in adults and in pediatric patients weighing at least 40 kilograms? 4. What are the brand names of acetaminophen with codeine, Tylenol, Capital, with codeine? 5. What is the generic name of Tylenol and Capital, with codeine, acetaminophen with codeine? 6. What are the indications of Tylenol and Capital, with codeine? 1. Relief of mild to moderate pain. 2. Relief of moderate to severe pain. 3. It may be necessary to extend the above dosage ranges for patients with more severe pain or when there is a tolerance to narcotic analgesics. 7. What is the brand name of acyclovir, Zovirax? 8. What is the generic name of Zovirax, acyclovir? 9. What are the indications of Zovirax, generic name, acyclovir? 1. Genital herpes simplex. 2. Genital herpes simplex suppressive therapy. 3. Herpes zoster, shingles. 4. Varicella, chickenpox. 5. Cold sores, oral labile HSV treatment. 10. What is the brand name of albuterol sulfate, inhalation, Preventil HFA, Ventolin HFA, and ProAir HFA? 11. What is the generic name of Preventil HFA, Ventanil HFA, ProAir HFA, albuterol sulfate, inhalation? 12. What are the indications of albuterol sulfate, inhalation? 1. Relief of bronchospasm in patients with reversible obstructive airway disease. 2. Maintenance to prevent exacerbations of bronchospasms, asthma. 3. Prevention of exercise-induced bronchospasms. 13. What is the brand name of albuterol sulfate, oral, Preventil? 14. What is the generic name of Preventil, albuterol sulfate, oral? 15. What are the indications of albuterol sulfate, oral? 1. For the relief of bronchospasm in adults and children 6 years of age and older with reversible obstructive airway disease. 16. What is the brand name of Adipiline, Differin, Plixta? 17. What is the generic name of Differin, Plixta, Adipiline? 18. What are the indications of Differin, Plixta, generic name, Adipiline? 1. Acne vulgaris. Adults and children greater than 12 years of age, apply thin film topically to affected area, S, daily HS. 19. What is the brand name of albendazole, Albenza? 20. What is the generic name of Albenza, albendazole? 21. What are the indications of Albenza, generic name, albendazole? 1. Parenchymal neurocysticercosis caused by Tinea solium, cystic hydatid disease of the liver, lung, and peritoneum caused by Echinococcus granulosus. 22. What is the brand name of alendronate, Fosamax, Binosto? 23. What is the generic name of Fosamax, Binosto, alendronate? 24. What are the indications of Fosamax, Binosto, generic name, alendronate? 1. For the treatment of osteoporosis in postmenopausal women, confirmed by the finding of low bone mass or by the presence of history of osteoporotic fracture. 2. For the prevention of osteoporosis in postmenopausal women. 3. To increase bone mass in men with osteoporosis. 4. Treatment of glucocorticoid-induced osteoporosis in men and women. 5. For the treatment of Paget's disease of bone. 25. What is the brand name of alfuzosin hydrochloride, Urazetrol? 26. What is the generic name of Urazetrol, alfuzosin hydrochloride? 27. What are the indications of Urazetrol, genetic name, alfuzosin hydrochloride? 1. For the treatment of signs and symptoms of benign prostatic hyperplasia, 1 tablet daily taken with food and with the same meal every day. Tablets should not be chewed or crushed. 28. What is the brand name of allopurinol, Xyloprim? 29. What is the generic name of Xyloprim, allopurinol? 30. What are the indications of Xyloprim, generic name, allopurinol? 1. Treatment of gout, primary or secondary to blood dyscrasias and their therapy, and uric acid nephropathy, primary or secondary, with or without symptoms of gout. 2. Prevention of uric acid nephropathy in patients undergoing vigorous therapy of neoplastic disease. 3. Prevention of flare-up of acute gouty arthritis. 4. Secondary hyperuricemia associated with malignancy. 5. Treatment of recurrent calcium oxalate stones. 31. What is the brand name of alprazolam, Xanax, XR? 32. What is the generic name of Xanax, XR, alprazolam? 33. What are the indications of Xanax, generic name, alprazolam? 1. Management of anxiety disorders or for the short-term relief of the symptoms of anxiety or anxiety-associated depressive states. 2. Treatment of panic disorder. 3. Treatment of panic disorder with or without agoraphobia. 34. What is the brand name of amantadine hydrochloride, Simitrel? 35. What is the generic name of Simitrel, amantadine hydrochloride? 36. What are the indications of Simitrel, generic name, amantadine hydrochloride? 1. Treatment of idiopathic Parkinson's disease, post-encephalitic Parkinsonism, symptomatic Parkinsonism following carbon monoxide intoxication, and drug-induced extrapyramidal reactions. 2. Treatment of uncomplicated respiratory tract illness caused by influenza A virus strains and prophylaxis of influenza A virus illness. 37. What is the brand name of amiodarone, cortisone, pacerone, nixterone? 38. What is the generic name of cortisone, pacerone, nixterone, amiodarone? 39. What are the indications of cortisone, pacerone, nixterone, generic name, amiodarone? 1. For the treatment of recurrent ventricular fibrillation and recurrent hemodynamically unstable ventricular tachycardia in patients who are unresponsive or cannot tolerate other antiarrhythmic agents. 2. For treatment and prophylaxis of frequently recurring ventricular fibrillation and hemodynamically unstable ventricular tachycardia in patients refractory to other therapy and in patients unable to take oral amiodarone. 3. Secondary prophylaxis of ventricular arrhythmias. 40. What is the brand name of amitriptyline hydrochloride, L-level? 41. What is the generic name of L-level, amitriptyline hydrochloride? 42. What are the indications of L-level, generic name, amitriptyline hydrochloride? 1. For the relief of the symptoms of depression. 2. Not recommended for use in children under 12 years of age. 43. What is the brand name of amlodipine mesylate, Norvasc? 44. What is the generic name of Norvasc, amlodipine mesylate? 45. What are the indications of Norvasc, generic name, amlodipine mesylate? 1. Treatment of hypertension. 2. Treatment of chronic stable or vasospastic angina. 46. What is the brand name of amlodipine mesylate with benazepril hydrochloride, Lotrel? 47. What is the generic name of Lotrel, amlodipine mesylate with benazepril hydrochloride? 48. What are the indications of Lotrel, generic name, amlodipine mesylate with benazepril hydrochloride? 1. Treatment of hypertension. The lowest dose of amlodipine is favorable to avoid peripheral edema. Use this combination in patients who failed to achieve desired effects with one or the other monotherapy or in patients who failed to achieve desired effects with amlodipine without developing edema. 49. What is the brand name of amoxicillin trihydrate, Amoxil, Moxitoc, Trimox 50? What is the generic name of Amoxil, Moxitoc, Trimox, amoxicillin trihydrate? 51. What are the indications of Amoxil, Moxitoc, Trimox, generic name, amoxicillin trihydrate? 1. Infections due to susceptible strains of the following gram-negative organisms, H. influenza, E. coli, P. mirabilis, and N. gonorrhoeae. Also indicated in certain infections caused by susceptible strains of the following gram-positive organisms: streptococci, non-penicillinase producing staphylococci, and D. pneumoniae. 2. Gonorrhea and acute uncomplicated urethral and anogenital infections due to N. gonorrhoeae. 3. Acute otitis media. 4. Lower respiratory tract infection. 5. Pharyngitis, tonsillitis. 6. Streptococcal pharyngitis. 7. Ear, nose, and throat infection, infection of skin and/or subcutaneous tissue, infection of genitourinary system. 8. H. pylori GI tract infection. 52. What is the brand name of amoxicillin with clavulinate potassium, Augmentin, Augmentin XR? 53. What is the generic name of Augmentin, Augmentin XR, amoxicillin with clavulinate potassium? 54. What are the indications of Augmentin, Augmentin XR, generic name? Amoxicillin with clavulinate potassium. 1. Acute otitis media. 2. Community-acquired pneumonia. 3. Lower respiratory tract infection. 4. Sinusitis, infection of skin or subcutaneous tissue, infectious disease of genitourinary system. 5. Urinary tract infection, acute cystitis. 6. Urinary tract infection, pyelonephritis. 55. What is the brand name of amphetamine with dextroamphetamine salts, Adderall, Adderall XR? 56. What is the generic name of Adderall, Adderall XR, amphetamine with dextroamphetamine salts? 57. What are the indications of Adderall, Adderall XR, generic name, amphetamine with dextroamphetamine salts? 1. Treatment of the symptoms of narcolepsy. 2. Treatment of attention deficit disorder with hyperactivity. 58. What is the brand name of anastrozole, Arimidex? 59. What is the generic name of Arimidex, anastrozole? 60. What are the indications of Arimidex, generic name, anastrozole? 1. For the adjuvant treatment of postmenopausal women with hormone receptor positive early breast cancer. 2. For the first-line treatment of postmenopausal women with hormone receptor positive or hormone receptor unknown locally advanced or metastatic breast cancer. 3. For the treatment of advanced breast cancer in postmenopausal women with disease progression following tamoxifen therapy. 61. What is the brand name of apazaban, Eliquis? 62. What is the generic name of Eliquis, apazaban? 63. What are the indications of Eliquis, generic name, apazaban? 1. For the reduction of risk of stroke and systemic embolism in non-valvular atrial fibrillation. 2. For prophylaxis of DVT following hip or knee replacement surgery. 3. For the treatment of DVT and PE. 4. Reduction in the risk of recurrent DVT and PE following initial therapy. 64. What is the brand name of arformoterol, Brovina? 65. What is the generic name of Brovina, arformoterol? 66. What are the indications of Brovina, genetic name, arformoterol? 1. For the long-term maintenance treatment of bronchoconstriction in patients with chronic obstructive pulmonary disease including chronic bronchitis and emphysema. 67. What is the brand name of aripiprazole, Abilify? 68. What is the generic name of Abilify, aripiprazole? 69. What are the indications of Abilify, generic name, aripiprazole? 1. For the treatment of schizophrenia. 2. For the treatment of acute manic and mixed episodes associated with bipolar disorder. 3. Depression, adjunctive with antidepressant. 4. Tourette syndrome. 5. Irritability with autistic disorder. 70. What is the brand name of atozanavir, Riataz? 71. What is the generic name of Riataz, atozanavir? 72. What are the indications of Riataz, generic name, atozanavir? 1. Treatment of HIV-1 infection, antiretroviral naive. 2. Treatment of HIV-1 infection, patients with prior virologic failure. 3. Treatment of HIV-1 infection in pregnant patients, antiretroviral naive or experienced. 73. What is the brand name of atenolol, tenormin? 74. What is the generic name of tenormin, atenolol? 75. What are the indications of tenormin, generic name, atenolol? 1. Management of hypertension. 2. Angina pectoris. 3. Usage in severe renal impairment. 76. What is the brand name of atomoxetine hydrochloride, Stratera? 77. What is the generic name of Stratera, atomoxetine hydrochloride? 78. What are the indications of Stratera, generic name, atomoxetine hydrochloride? 1. For the treatment of attention deficit/hyperactivity disorder, ADHD, with or without comorbid anxiety disorder. 79. What is the brand name of atorvastatin calcium, Lipitor? 80. What is the generic name of Lipitor, atorvastatin calcium? 81. What are the indications of Lipitor, generic name, atorvastatin calcium? 1. Hyperlipidemia. 2. Primary and secondary prevention of atherosclerotic cardiovascular disease. 3. Secondary prevention of cardiovascular events in patients with or at high risk for CAT. 4. Familial hypercholesterolemia, homozygous. 82. What is the brand name of azathioprine, Azamoin, Imuran? 83. What is the generic name of Azamoin, Imuran, azathioprine? 84. What are the indicients of Azamoin, Imuran, genetic name, azathioprine? 1. Renal transplantation. 2. Rheumatoid arthritis. 85. What is the brand name of azelastine hydrochloride, nasal, Astelin, Astepro? 86. What is the generic name of Astelin, Atepro, azelastine hydrochloride? 87. What are the indications of Astelin, Astepro, generic name, azelastine hydrochloride? 1. For the treatment of the symptoms of non-allergic vasomotor rhinitis and seasonal allergic rhinitis such as rhinorrhea, sneezing, and nasal pruritus in adults and children 12 years and older. 2. Perennial allergic rhinitis. 3. Seasonal allergic rhinitis. 4. Vasomotor rhinitis. 88. What is the brand name of azithromycin dihydrate, Zithromax, Zmax? 89. What is the generic name of Zithromax, Zmax, azithromycin dihydrate? 90. What are the indications of Zithromax, Zmax, generic name, azithromycin dihydrate? 1. Acute infective exacerbation of COPD, skin or tissue infection. 2. Bacterial sinusitis. 3. Chancroid, non-gonococcal cervicitis, non-gonococcal urethritis. 4. Community-acquired pneumonia. 5. Sexually transmitted infections. 6. Streptococcal pharyngitis. 1/6.
Okay, welcome to the New Chemist Podcast, episode 3C. We go back to the basics and discuss fundamental ideas that support an understanding of pharmacy ideas. And we're using the format of a telephone conversation. This is definitely an episode worth listening to. So it's important to note that the purpose of these episodes are not at all medical advice, medical suggestions, or medical counsel. These are aimed to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Again, please note that these are not at all medical advice, medical suggestions, or medical counsel. Please see your local state and board certified physician, physician assistant, or nurse practitioner, and pharmacist for medical advice and suggestions. Once again, these are not at all for medical advice, suggestions, or counsel. Please see your local state and board certified physician, physician assistant, or nurse practitioner, and pharmacist for medical advice, suggestions, and counsel. The views in this podcast represent those of my guests and I. So, pharmacy school is a blast. However, you must be very dedicated.
and maintain a good integration of your self-care regimen, as well as your personal affairs, as well as your academic responsibilities. So let's run through a few quick facts and then we'll conclude this episode for today. So pharmacokinetics, it's what the body does to the drug. We're talking about absorption, distribution, metabolism, and excretion over time. What's the goal of pharmacokinetics? We want to control the amount of drug exposure. So let's talk about respiratory alkalosis. It involves a rise in blood pH due to hyperventilation, so that's excessive breathing, and a resulting decrease in carbon dioxide. Let's talk about acidosis. What is it? Blood pH lower than 7.35. So let's also talk about extravascular drug absorption. That involves oral, stomach, absorbing the intestine, metabolizing the liver. Some amount of drug reaches the systemic circulation, and the rest of the drug is excreted. Let's talk about intravascular drug absorption. Actually, we'll come back to that. Let's talk about the first pass effect. The initial metabolism in the liver of a drug absorbed from the gastrointestinal tract before the drug reaches systemic circulation through the bloodstream. Let's say that again. First pass effect. The initial metabolism in the liver of a drug absorbed from the gastrointestinal tract before the drug reaches systemic circulation through the bloodstream. Let's also talk about enterohepatic cycling. Drugs are transported through the bile back to the intestine, where they can be reabsorbed in the intestines, increasing the duration of action. One more time. Enterohepatic recycling. Drugs are transported through the bile back to the intestine, where they can be reabsorbed in the intestines, increasing the duration of action. So when we administer intravenously, we have 100% bioavailability. Intravascular administration involves IV as well as intraarterial. Local activity, it will involve things like general pulmonary, topical, ocular, intraocular. Systemic activity will involve things like oral, sublingual, buccal, intramuscular, subcutaneous. Selective beta blockers. So we're just running through a litany of facts that are useful. It's primarily under the umbrella of pharmacy basics. We're just running through some ideas quickly, just to give people a quick refresher for those who are in training at this time. Selective beta blockers: metoprolol, atenolol, all, bisoprolol, nebivolol, acebutolol, betaxolol, esmolol. How is the drug absorbed? Active transport with transport proteins or passive diffusion. So we already mentioned how intravascular administration involves intravenous and intraarterial. Let's see what else can we talk about. So let's talk about dissolution. It's a process of drugs dissolving in the GI tract. Dissolution rate, we look at the Noyes-Whitney equation. Smaller the particle size, the greater the absorption. Increasing the surface area increases the drug absorption. Let's make a quick note of that. Dissolution rate, we look at the Noyes-Whitney equation. Smaller the particle size, the greater the absorption. Increasing the surface area increases the drug absorption. Almost rhymes. Now, how to limit drug degradation? You have your enteric coating, biodegradable polymers, so acidic environment in the stomach won't destroy the drug, increasing the amount of drug absorption. Bioavailability. Amount of drug available systemically to produce an effect. So how much of the drug is available in the drug to produce a therapeutic effect. So how much is available to produce a therapeutic effect? So formula percent of drug absorbed. The amount appears in systemic circulation or the amount administered. High bioavailability is above 70%. Low bioavailability is below 10%. Let's go back to that again. Formula percent of drug absorbed. Amount appears in systemic circulation over the amount administered. So amount appears in systemic circulation over the amount administered. High bioavailability is above 70%, whereas low bioavailability is below 10%. So let's see. Let's give an example. So if we have if we administered 100 milligrams of a drug orally, and 20 milligrams appears in systemic circulation. 20 over 100 is the same thing as 0.2. Multiply by 100 when we're talking about percent, it gives us 20%. Okay. And from the framework that we just discussed, that will give you an idea as to what extent or what amount of bioavailability is occurring with that problem. So drugs with 100% oral bioavailability: levofloxacin, linezolid. So those are examples of two. So formula for bioavailability: area under the plasma, concentration time curve representing total drug exposure. That's a mouthful. Let's go over that again. Formula for bioavailability: area under the plasma, concentration time curve representing total drug exposure. Okay, there are formulas for that. We can discuss that later. So what are the physical-chemical properties that affect drug distribution? Lipophilicity. Lipids can easily cross the membrane. All the things that affect this drug distribution: molecular weight, ionization status. The charged particles cannot pass, non-charged particles can pass, and protein binding. So lipophilicity, molecular weight, ionization status, and protein binding. So LIMP, L-I-M-P, lipophilicity, ionization status, molecular weight, protein binding. Those are the lens to which you look at, or basically the parameters that you kind of look at when you're trying to determine understand what's affecting drug distribution. Also, let's go back to the formula for bioavailability. 100 times AUC subscript EX over AUC subscript IV times dose subscript IV over dose EX. So it's important to note that EX is referring to extravascular, IV is referring to intravenous, AUC is referring to area under the curve. 100 is being used because we're talking about percent, and F is absolute bioavailability. Let's run that back one more time. F is absolute bioavailability. We multiply by 100 because we're talking about percent. AUC is area under the curve. IV is referring to intravenous. EX is referring to extravascular. So F is 100 times AUC EX over AUC IV, and that whole thing is multiplied by dose IV over dose EX. So high protein binding. Drug has high affinity for albumin, so the amount of free drug will be low. The albumin acts as a reservoir for the drug, and it releases the free drug in small amounts to the tissue to exert its effect. This increases the duration of action. High protein binding. Drug has a high affinity for albumin, so the amount of free drug will be low. The albumin acts as a reservoir for the drug, and it releases the free drug in small amounts to the tissue to exert its effect. This increases the duration of action. 28. Albumin. So protein in the blood that's made in the liver. So let's keep going. When a correction form, site-specific drug delivery. Antibodies bind to particular receptors on specific tissues or organs. Site-specific drug delivery involves antibodies binding to particular receptors on specific tissues or organs. So when are correction formulas needed? Highly bound protein drugs with patients whose serum albumin is low. Examples of highly protein bound drugs: phenytoin, warfarin. Examples of those. Let's look and see. What else can we talk about? Calcium corrected formula. So calcium, in brackets, reported serum plus, in brackets, 4.0, subtracting the albumin amount, and that difference is multiplied by 0.8. Phenytoin corrected formula. Total phenytoin measured over, in brackets, 0.2 times the albumin amount plus 0.1. So the product of 0.2 times the albumin amount in the brackets added to 0.1, the whole thing is the denominator, under the numerator, which is total phenytoin measured. So volume of distribution, this is the amount of drug in body over plasma drug concentration. Okay, so small volume of distribution involves it being confined to plasma or extracellular space. Example, tobramycin, 0.2 liters per kilogram. Large volume distribution, wide distribution to all body tissues, so the plasma drug concentration is low. Tetracycline is an example of that, 7 to 9 liters per kilogram. So guys, what kind of volume of distribution would you want a drug to have if you were treating a systemic infection? You can think about that and process that in your healthcare profession class or science class. Okay. Let's see what else to talk about. So metabolism involves the process by which a drug is converted from its original chemical structure to other chemical forms. The original chemical form is the parent drug. Other chemical forms, metabolites, occurs primarily in gut and liver. You want the drug to be lipophilic so it can cross the phospholipid bilayer and exert its effects on the tissues. The body undergoes multiple biological reactions to make these intermediates hydrophilic so that they can be excreted by the body. Okay, so lidocaine undergoes extensive first-pass metabolism in the liver, so it's only administered, or typically administered in the intravenous form. Okay. Excretion, irreversible removal of the drug from the body. Organs for excretion, you have the kidneys, and that results. Kidneys function to produce urine. The gut, GI tract, basically functions to produce feces. Lungs function to produce exhaled air. The skin functions to produce sweat. The liver functions to produce bile. So clearance is defined as the volume of plasma cleared of a drug over a period of time. Clearance is defined as the volume of plasma cleared of a drug over a period of time. Okay, two formulas for clearance involve the rate of elimination over concentration. Also, F times dose over area under the curve. Okay, so half-life, the time in which 50% of the drug is eliminated, T1/2. So first order elimination, constant percentage of drug is removed per unit time. The drug concentration is eliminated, and that's directly proportional to the concentration of the drug. Okay. Let's see what else we can talk about. Let's see. So, zero order elimination, the constant amount of drug is eliminated per unit time. So Michaelis-Menten kinetics, this is like, if you've done biochemistry and you're now in the pharmacy program, this is an idea that you see over and over and over again. So, let's think. Michaelis-Menten kinetics, you have your mixed order, saturable or non-linear kinetics. Increasing the dose leads to disproportionate increase in concentration. First section of the curve, lots of available enzymes. Second section, composition of enzymes, more drugs than binding sites available on enzyme. Third section, all the active sites on the enzymes are occupied. The drug is not being metabolized, leading to toxicity. So let's keep going. Km, concentration at half max of Vmax. Michaelis-Menten drugs, phenytoin, theophylline, voriconazole. Okay, let's keep going. It's important to note that let's just talk about a quick case scenario. The patient has been using phenytoin 100 milligrams 3 times daily. So TID, the phenytoin level was drawn and found to be 8.8 micrograms per milliliter, reference range 10 to 20 micrograms per milliliter. The prescriber doubled the dose to 200 milligrams 3 times daily, so TID. The patient started to slur words, felt fatigue, and returned to the clinic. The level was repeated and found to be 23.7 micrograms per milliliter. Which of the following is accurate regarding the most likely reason for the change in phenytoin level? So, what we understand is phenytoin metabolism can become saturated at higher doses. Phenytoin metabolism can become saturated at higher doses. Saturation point. Let's keep going now. Saturation point. Adding more substrate will make no difference in the reaction rate. Good rule of thumb for phenytoin: if there is 7 micrograms per milliliter in the serum, adjust doses in small increments, no more than 30 to 50 milligrams at a time. So KE is the elimination rate constant. Let's see. The loading dose. Use of a higher dose than what is usually used for treatment to allow the drug to reach the concentration that exerts the therapeutic effect. As we progress, one of these episodes, we'll spend some time talking about therapeutic effects and therapeutic indices, therapeutic windows. Okay, so let's keep going. We're going to talk about some pharmacology basics now. Pharmacology is a body of knowledge concerned with the actions of chemicals on biological systems. What is medical pharmacology? It involves the use of chemicals in prevention, diagnosis, and treatment of disease. What is toxicology? It is concerned with the undesirable effects of chemicals on biological systems. What is pharmacokinetics? It involves what the body does to the drug. You have your ADME, your absorption, your distribution, your metabolism, your excretion. What is pharmacodynamics? How I think about this is when I look at the word, D comes with 4 of the letters, M, A, and N. So it's what the drug does to the body, or drug does to the man. That's how I see it. That's how I process this. So pharmacodynamics, what the drug does to the body. What is onset of action? Is how much of the drug comes into circulation to produce the effect, determined by the route of administration and drug dosage. When you increase the drug dosage, the concentration of drug in the body will also increase. So what is onset of action? Is how much of the drug comes into circulation to produce effect. The effect, determined by the route of administration and drug dosage. When you increase drug dosage, the concentration of drug in the body will also increase. So what is duration of action affected by, or what can be affected by? The drug dosage, or higher the dosage. It also can be affected by the rate of distribution, the rate of metabolism, and the rate of excretion. So MEC, minimum effective concentration. It's the amount of drug required to produce a therapeutic effect. So what is the duration of action? It's the time between the rise to the decline at minimum effective concentration for therapeutic effect. What is the MOA, the mechanism of drug action? Drugs cannot produce any new action in the body, can act on enzymes, ion channels, upregulate or downregulate the system within the body. So there are some more things we want to talk about. Ligands, so they're signaling molecules, RA, receptor existing in the active state, RI, receptor existing in the inactive state. Depending on whether you read, some people refer to, like in biochemistry, is referred to, they use different letters to describe those things in undergrad biochemistry. But for now, in this phase, we'll talk about RA being a receptor existing in an active state, RI, receptor existing in an inactive state. So the external receptor site. Ligands bind outside plasma membrane and produces change inside the cell. These are elegantly displayed with receptor proteins on the phospholipid bilayer. So internal receptor site. Drugs go inside the cell, bind the receptor inside the cell, moves to the nucleus to produce desired effect. So mechanisms of agonist-mediated activation. You have your ion channels, your GPCRs, wonderful group, class of receptors, just excellent. Wonderful family, if you will. receptor tyrosine kinases, intracellular hormone receptors. So those are things you want to like focus in on. Ion channel ligand, gated voltage, gated second messenger regulated. Ligand gated ion channel, drug binds the ion channel, activating it to open. Sodium enters, triggering an action potential. Voltage gated ion channel, change in charge or potential between the inside of the cell and the outside of the cell, causing the channels to open to maintain internal homeostasis. Inside the cell, the charge is between negative 70 millivolts and negative 90 millivolts to open the gate to maintain internal homeostasis. Okay, let's go. Second messenger regulated. Various second messengers are regulatory channels by opening and closing them. Some include calcium and cyclic AMP. Cyclic AMP can cause the activation of enzymes which trigger signal transduction pathways. So your GPCRs, your guanine protein coupled receptors, a signal receptor protein in the plasma membrane that responds to the binding of a signal molecule by activating a G protein, also called a G protein linked receptor. Your RTKs, receptor tyrosine kinases. Insulin binds to tyrosine kinase receptor. Tyrosine kinase receptor undergoes autophosphorylation. Insulin receptor is activated. Downstream cascade of signals. Final signal is to recruit glucose transporters, GLUT. Move from cytosol to plasma membrane and take these into tissues for utilization or storage. So let's talk about some amino acids for a bit. Just for a quick bit, we know some amino acids with hydroxyl groups are your serine, tyrosine, and threonine. So serine, if you go from the peptide backbone and walk down the R group, you have, so serine has the methionine spacer, and hydroxyl tyrosine has your methionine spacer, your benzyl ring, and then your hydroxyl. And threonine has a methine spacer, then a methyl group that comes off from that, and then a hydroxyl group. Okay, so kinase is the enzyme that causes phosphorylation. If you want to look up the spacers in terms of methionine, CH2, methine, CH is what we're referring to. We say those spacers. That's kind of organic chemistry talk, or speak, if you will, for those who are organic chemistry majors or who study some organic chemistry. So let's talk about kinases, enzymes that cause phosphorylation. So intracellular hormone receptor, mostly steroids, enter the cell easily because they are lipids, bind to receptors inside the cellular cytoplasm, get activated, move to the nucleus, cause DNA transcription, which leads to the formation of particular proteins. So affinity, the measure of tightness in which a drug binds to a receptor. What is intrinsic activity? So the ability of a drug to activate a receptor upon binding. An agonist is a drug that mimics the action of the endogenous ligand. Primary agonist, drug binds the same recognition site as the endogenous agonist. So I've heard of allosteric, but this was a new one for me. Orthosteric. Orthosteric site, the primary or the right binding site. Allosteric agonist binds to a different region of the receptor. So allosteric is referring to another. That's what that word means, literally. Antagonist, drugs that block or reduce the activity of an agonist. So antagonist blocks the agonist. Antagonist. And these have affinity but no intrinsic activity. And remember, intrinsic activity is the ability of a drug to activate a receptor upon binding. Asymptotic interaction, competition with agonists for the same overlapping site. Asymptotic interaction, competition with agonists for the same or overlapping site. You got your physical antagonist. Physically interacts and nullifies the action of the drug. Example, charcoal, which is a good absorbent. It binds to alkaloid to form a complex and will be excreted. The chemical antagonist, the drug forms compounds with other substances like calcium and magnesium. Example, tetracycline binds to calcium in milk and then will be eliminated. You have your physiological antagonist, a drug that counters the effects of another by binding to a different receptor and causing opposing effects. Drugs that produce an opposite action by binding to a different receptor. Example, adrenaline is a physiological antagonist to histamine because adrenaline causes bronchodilation and histamine causes bronchoconstriction. Pharmacological antagonists. The drug that binds to the receptor and produces no effect and shows no intrinsic activity. And remember, intrinsic activity is basically the ability of a drug to activate a receptor upon binding. Partial agonists. A drug that binds to a receptor and causes a response as less than that caused by a full agonist. You have your inverse agonists. In the stomach, histamine receptors are constitutively activated. They're activated without stimulus. So under normal conditions, they're operating at 20%. Inverse agonists inhibit these receptors, bringing them down to 0%. Competitive agonists, same binding site as agonists, resembles chemically with agonists. You have a right shift on the dose-response curve. Response depends on concentration. So your dose and response, your dose can be considered like your X value. Your response can be considered like your Y value, if you will. So you plot. So non-competitive agonists, different binding site of agonists, not resemble chemically, a downward shift of dose-response curve. Increasing agonist concentration won't make a difference. So one more time, non-competitive agonists, you have a different binding site of agonists, not resembled chemically, you have a downward shift of the dose-response curve. Increasing agonist concentration won't make a difference in this case, or in that case. So how do we activate receptor sites? You open or close ion channels, speed up or slow down transporters, increase or decrease enzyme activity. So efficacy. What is efficacy? It is the maximum effect a drug can produce. It can be measured with a graded dose response curve. Potency is the amount of drug needed to produce a given effect, determined by affinity of the receptor for the drug. So EC50, the dose is required for an individual to experience 50% of the maximum effect. ED50, the dose required to produce a therapeutic effect in 50% of the population. Median effective dose. So your therapeutic index, it's a ratio. It compares the blood concentration at which a drug becomes toxic and the concentration at which the drug is effective. Your LD50 over your ED50. 10 to 1 safer drug because it has a wider therapeutic index. 3 to 1 more dangerous drugs needs more attention because the therapeutic index is narrow. LD50, median lethal dose. So tolerance. What is tolerance? Reduced response to drug after prolonged use, develops gradually over a long period of time. For example, alcoholics need more alcohol on the second day to feel the same effect from the first. If it's accustomed to alcohol, so their infants are ready. So let's talk about pharmacokinetic tolerance. It involves the enhanced enzymatic breakdown. It reduces the amount of drug reaching its site of action. Example, barbiturates, carbamazepine, reduce their own metabolism. So oil metabolism or oil destruction on frequent repeated use. So pharmacodynamic tolerance. So you had your pharmacokinetic tolerance. Let's talk about pharmacodynamic tolerance. It is the tolerance caused by altered nervous system sensitivity, change in receptors. It involves the action of drug is being reduced because of down-regulation of receptors, meaning that receptor expression or the amount of receptor present will be less. The receptor is not active as before, or it involves the sensitization of receptors, meaning the receptors will not function as well. So proteins could go through PTMs or post-translational modifications, meaning that they lose, for example, a sulfide due to the drug use, losing their function. Some changes are reversible, others are not. And internalization, and that internalization of receptors, so receptor will not be available, and exhaustion of mediators, depletion of catecholamine or epinephrine as well. So natural inherent tolerance involves a genetic makeup, makes an individual resistant or will have more response to a drug. Acquired tolerance occurs when repeated use of drug. Tolerance develops to sedative action of chlorpromazine, but not its antipsychotic action. Tolerance occurs to sedative action of phenobarbital, but not to its anti-epileptic action. So cross-tolerance. Development of tolerance to pharmacologically related drugs. For example, partial tolerance between morphine and barbiturates. And then you also have complete cross-tolerance between morphine and pethidine, same drug class. So what is tachyphylaxis? It's a type of tolerance that occurs rapidly within minutes or seconds when it takes a small concentration of drug to cause this. So what are some drugs that have a low or narrow therapeutic index? You have your acetaminophen, your theophylline, carbamazepine, digoxin, warfarin, lithium, phenytoin, gentamicin, vancomycin, antidepressants, bicyclic insulin. Let's talk some more. And what are your drugs with the narrow therapeutic index? Acetaminophen, theophylline, carbamazepine, digoxin, warfarin, lithium, phenytoin, gentamicin, vancomycin, antidepressants, bicyclic insulin. So drugs with a high or wide therapeutic index are your NSAIDs, your non-steroidal anti-inflammatory drugs, your benzodiazepines, most antibiotics, furosemide, and your SSRIs. Nitroglycerin can cause tolerance. As a pharmacist, you must tell the patient you need to have a 10 to 12 nitrate-free period to prevent tolerance. Nitroglycerin causes vasodilation. Let's keep going. Synergism. One drug is going to have an additive effect with another drug, increasing efficacy. Action of one drug is facilitated or increased by another drug, or when one drug is inactive alone but active when combined with another. Additive, the effect of two drugs in the same direction. Example, amlodipine. Okay, so let's keep going. Let's keep going. So we also have, so example, so you have the additive, the effect of two drugs in the same direction. Example, amlodipine and atenolol, all antihypertensive. Amlodipine is a calcium channel blocker, and atenolol is a beta blocker. Both work to reduce hypertension and act on different places in the heart. You have glibenclamide, and metformin. Hypoglycemic glibenclamide is a sulfonylurea that increases insulin receptor sensitivity and causes secretion of insulin, acts on pancreas. Metformin acts on liver to control blood glucose level. So super additive, otherwise known as potentiation. The effect of the combination is greater than the individual effects of each component. Acetylcholine and physostigmine. Acetylcholine acts on muscle produce effect. Physostigmine is inactive. Both are degraded by acetylcholinesterase. When acetylcholine is alone, the enzyme will break it down quickly. You have physostigmine. With it, the enzyme doesn't know which one to attack. Competition between the two, so it increases the duration of acetylcholine. Levodopa and carbidopa. Levodopa treats Parkinson's disease by converting to dopamine to prevent movement disorder. When taken orally, levodopa is converted to dopamine in the intestine, causing adverse effects like nausea and vomiting. Give it with carbidopa, which prevents the breakdown of the intestines, so it can be transported to the brain, across the blood-brain barrier, where it can be converted to dopamine to act on the basal ganglia, sulfamethoxazole/trimethoprim. Inhibits two enzymes, inflammation of tetrahydrofolic acid, which is required for bacterial cell wall synthesis. If you want to kill the bacteria, you need sulfamethoxazole to prevent the conversion of PABA to an intermediate product. And then you need trimethoprim to prevent the conversion of the intermediate product to tetrahydrofolic acid. So enalapril and hydrochlorothiazide. Enalapril, angiotensin converting enzyme inhibitor. Hydrochlorothiazide, diuretic, acts in two different places to produce the antihypertensive effect. So let's wrap this up. Drug action and enzymology. So the ES is referring to your enzyme substrate complex. The enzyme, a type of protein that speeds up a chemical reaction in a living thing. Enzymes are globular proteins, very specific. Substrate, reactant, EP, enzyme product complex, irreversible inhibition of enzymes caused by covalent bonds. Enzymes cannot be regenerated. The only way the product can be catalyzed is when new enzyme molecules are produced in the body. Reversible inhibition of enzymes. Enzymes can be freed from the complex to give the active enzyme. Ka, association constant of ligand with receptor site. Kd, association constant for the receptor. EC50, drug concentration giving a response halfway between the baseline and maximum. IC50, concentration which produces 50% of the maximum possible inhibitory response, which is equal to the Quantal response. Quantal response equals IC50. So affinity, the ability of a compound to bind tightly to the target. Intrinsic activity, the drug's ability to produce an effect once bound to the receptor. Potency, the amount of drug needed to produce an effect. The more potent the drug, the steeper the slope on the DRC, or the dose response curve. Efficacy. So efficacy. The potential maximum therapeutic response a drug can have, for example, furosemide eliminates more salt in water than chlorothiazide, so furosemide has a higher efficacy. Efficacy, the potential maximum therapeutic response a drug can produce. Allosteric site, or allosteria is referring to another, it's a site the drugs bind to that exerts their activity that's not the actual receptor site of the endogenous ligand. So isosteres, which is a nice word, replacement of modifications of functional groups with other groups having similar properties. So replacement or modifications of functional groups with other groups having similar properties. It tunes, make sure you remember that word, tunes the drug metabolism, receptor fit distribution, and other properties. So bioisosterism, swapping of functional groups present in the chemical compound while maintaining the desired biological activity. Corrects undesired properties. So let's wrap this up. This involves starting with the parent compound and using isosteres, which involves slightly changing the general structure to make more desirable structures. These are analogs. So isosteres of hydrogen, fluorine, isosteres of fluorine, hydroxyl, amine, so NH2 or CH3, in brackets H, isosteres of carbon, isosteres of hydroxyl, amine, isosteres of sulfur hydroxyl, isosteres of chlorine, and trifluoromethyl. So this is the end of the episode.
Okay, so this will be an addendum to the episode in which we discuss some common abbreviations outlined in pharmacy. Some of these are in Latin, many of these are in Latin. So AA dot, ana, of each, AD, up to make. So just draw back, AA dot, ana, which means of each, AD, add, which means up to or to make, DISP dot, dispensator, dispense, means to dispense, DIV dot, divator, divide, D dot T dot D, denter talis doses, which means give us such doses, FT fiat, which means to make, capital M dot mise, which means to mix, N, capital N, O dot numero, which means number, non, space, rep, REP dot, or NR, which both are capitalized, means non-repetitor, and that means to not repeat. QS, quantum sufficient, a sufficient quantity. QSAD, Q dot S dot AD, quantum sufficient add, a sufficient quantity to make. SIG dot signa, which means to write, in brackets directions on label. So some common abbreviations, you have BSA, body surface area, cm raised to the 3, cubic centimeter or milliliter. F or FL, fluid. Let's go through some more. G is gram, GAL is gallon, GTT, gutter, which means drop, I.U. or IU, international units, LB, libra, which means pound, kg, kilogram, L, liter, M to the second, or capital M to the second square meter, MCG, microgram, MEQ, milliequivalent, mg, milligram, mg over kg, milligrams of drug per kilogram of body weight, mg over m squared, milligrams of drug per square meter of body surface area, m, capital IU or milli, IU, thousandth of an international unit, capital M, capital I, capital U, million international units, ml, milliliter, ml per h, milliliters of drug administered per hour as through intravenous administration. M capital OSM or M capital OSMOL. So M capital O lowercase s lowercase m or M capital O lowercase s lowercase m OL milliosmoles. So OZ dot ounce, PT pint, QT quart, SS or SS with a line over both S's means 1/2, sem, TBSP dot tablespoonful, TSP dot teaspoonful, administer, AM antemeridium, morning, AQ dot aqua water dye twice a day. C or C with a line over it, come, which means with, D in bracket or dye, which means day, DIL dot dilutus, dilute, et, and H dot or HR dot aura, which means hour, HS aura somni at bedtime, IC intercibos between meals, MIN dot minutum minute, MN morning and night, N and V, both N and V are capitalized, nausea and vomiting, NOCT dot nocte night, NPO non per os, nothing by mouth, PC post cibos after meals, PM post meridium, afternoon or evening, PO per os by mouth or orally, PRN pro re nata as needed, Q quaque every, Q capital AM every morning, Q4H or Q8H etc. every number in brackets hours, QID quarter in die 4 times a day, QID quarter in die 4 times a day, rep dot repetitor repeat, S sine without, SID semel in die once a day, SOS C opposite if there is need as needed, SOS C opposite if there is need or as needed, stat stamnen immediately, PID tur and die 3 times a day, ut dictum as directed, WK dot week, so APAP acetaminophen, so a PAP acetaminophen, ASA aspirin, AZT zidovudine, EES erythromycin ethyl succinate, HC hydrocortisone, HCTZ hydrochlorothiazide, MTX methotrexate, NSAID non-steroidal anti-inflammatory drug, so MTX methotrexate, NSAID non-steroidal anti-inflammatory drug, NTG nitroglycerin. So clinical abbreviations, you have AFib atrial fibrillation, ADR adverse drug reaction. You also have BM bowel movement. All of these are capitalized. BP blood pressure, BS blood sugar, CAD coronary artery disease. CHD coronary heart disease, CHF congestive heart failure, COPD chronic obstructive pulmonary disease. Okay, COPD chronic obstructive pulmonary disease, GERD gastrointestinal reflux disease, CRF chronic renal failure, CV cardiovascular, ENT air, nose and throat, GI gastrointestinal, GFR glomerular filtration rate, GU genitourinary, HA headache, HPP heart rate, HR high blood pressure, HRT hormone replacement therapy, HT or HTN hypertension, HT or HTN hypertension, IOP intraocular pressure, MI myocardial ischemia / infarction. So MI myocardial ischemia / infarction. OA osteoarthritis, PT patient, QL quality of life. So P is capitalized, T is lowercase, patient, QL quality of life, RA rheumatoid arthritis, SOB shortness of breath, and that means dextrose 5% in lactated ringers, D5NS dextrose 5% in normal saline, in brackets 0.9% sodium chloride, D5W dextrose 5% in water, D10W dextrose 10% in water. ELIX dot, elixir INJ dot, so INJ dot injection, NS normal saline, half NS, half strength normal saline, oint or UNGT, unct, or that means, so unct, UNGT means unguentum, and that means ointment. So UNGT dot stands for unguentum, which means ointment. PULV dot pulvis, L dot solutio, solution. SUPP dot suppositorium, suppository. SUSP dot suspension, SUSP dot suspension. SYR dot syrupus, syrup. CAB dot tabletta, tablet. So routes / location of administration. A dot D dot aureus dextro, right ear. A dot S dot aureus sinistro, left ear. A dot U dot aureus utro, each ear, or both. Capital CIVI, continuous, in brackets 24 hours, intravenous infusion. ID, intradermal. INJ, injection. IM, intramuscular. IT, intrathecal. IV, intravenous. IVB, intravenous bolus. IV drip, intravenous infusion. IVP, intravenous push. IVPB, intravenous piggyback. NGT, nasogastric tube. NGT, nasogastric tube. O.D. oculodextro, right eye. O.S. oculosinistro, left eye. O.U. oculoutro, each eye, so both. P.O. or PO, per os, by mouth. REC. Or prorecto, rectal or rectum. So REC. Or prorecto, which means rectal or rectum. SL, both S and L are capitalized. Sublingual. SUBQ or SC, subcutaneously. TOP. Of the addendum.
An adaptation. No consternation. Once upon a time there was a professor who had 12 princes named Nemio Structurio and his brother Reactivio, Acidio and his brother Basissio, Nucleofelicio and his brother Electrofelicio, Equilibrio, Stereochemical, Sterico, and his brother Electronico, and Regio Selectivio. Each prince was more complementary than their brother. They all stayed in the mine town called Organico-Chemical. One evening when, during the mystical week known as finale, they all came together to compete at the yearly games. Nemio was notoriously a political person who voted for the PLP, aka Principal Locant Parent Chain Suffix. Principal Locant Parenting Suffix. Structure competed in the dance competition, showing his routines in the condensed and one-line forms. Reactilio participated in the track competition, particularly in the race called the Kinetic 500. Acidio and Basissio competed in the meditation competition, with Nucleofelicio stretching the farthest and Electrofelicio serving as the catcher for the cheerleaders. Equilibrio participated in the annual Estratius fencing competition. Furthermore, Stereochemical participated in the art competition focusing on the 3D drawings. Chemical and Electronico, being first rivals, compete in the rowing competition, with Sterico winning at points and Electronico winning at points. The boat race is still ongoing. Regio Selectivio competed in the map reading competition. These princes still compete today, and the story continues.
In the world of pharmacy, we lay the claim. Knowledge and compassion is the golden flame. Science and practice, side by side they groove. In a student's journey, we find the move.
Welcome to the New Chemist podcast.
Bienvenidos al podcast del nuevo químico.
Καλώς ήρθατε στο podcast του New Chemist. Welkom bij de podcast van The New Chemist.
Bienvenue sur le podcast du nouveau chimiste.
Bem-vindo ao podcast do novo químico.
Welcome to the New Chemist podcast. Work hard. Be value-driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here, rooting and cheering for you. Don't give up.
Travaillez dur. Soyez axé sur la valeur. Tu peux le faire. Vous pouvez grandir et l'apprendre. Vous pouvez être la différence dont vous et votre communauté avez besoin. N'abandonnez pas. Nous sommes ici pour vous encourager et vous encourager. N'abandonnez pas.
Trabalhar duro. Seja orientado por valores. Você consegue. Você pode crescer e aprender. Você pode ser a diferença que você e sua comunidade precisam. Não desista. Estamos aqui torcendo e torcendo por você. Não desista.
Δούλεψε σκληρά. Να οδηγείτε στην αξία. Μπορείς να το κάνεις. Μπορείτε να μεγαλώσετε και να το μάθετε. Μπορείτε να είστε η διαφορά που χρειάζεστε εσείς και η κοινότητά σας. Μην τα παρατάς. Είμαστε εδώ για να σας ζητοκραυγάσουμε. Μην τα παρατάς.
Trabaja duro. Sea impulsado por el valor. Puedes hacerlo. Puedes crecer y aprenderlo. Usted puede ser la diferencia que usted y su comunidad necesitan. No te rindas, estamos aquí animándote y animándote. No te rindas.
Werk hard. Wees waardegedreven. Je kunt het. Je kunt groeien en leren. U kunt het verschil zijn dat u en uw gemeenschap nodig hebben. Geef niet op. We zijn hier om voor je te roten en te juichen. Geef niet op.
Work hard. Be value-driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up. Thanks for listening. We're glad you were able to tune into this podcast. Once again, this is the New Chemist, where we discuss chemistry, which simply put is the science of change, as well as the other sciences, careers, community, research, and COVID-19. Thanks again for listening. Note, the views on this podcast represent those of my guests and I.
These views do not reflect the guest or interviewee today. These are solely the views of the original podcast host. This is my Father's world. I rest me in the thought of rocks and trees, of skies and seas, his hands the wonders wrought. 2 Corinthians 5:20 We are therefore Christ's ambassadors, as though God were making his appeal through us. We implore you on Christ's behalf, be reconciled to God. With that in mind, if you are curious about the growing success or progress of the podcast host, or any of his guests who are persons of faith, here is an optional open invitation to hear the gospel. In the words of Tim Keller, here is the gospel, quotes is, the gospel is this: we are more sinful and flawed in ourselves than we ever dared believe, yet at the very same time we are more loved and accepted in Jesus Christ than we ever dared hope. So if you are interested, feel free to pray this prayer with me. Dear Lord Jesus, I know that I am a sinner, and I ask for your forgiveness. I believe you died for my sins and rose from the dead. I turn from my sins and invite you to come into my heart and life. I want to trust and follow you as my Lord and Savior. In your name. Amen. If you believe that, you are now saved and a child of God. Take care. God bless, and look for Bible-teaching churches or gospel-based churches to grow and develop in Christ.
You are very important, especially to us here at the New Chemist podcasting group. You listening in is significant.
Vous êtes très important, surtout pour nous ici au New Chemist Podcasting Group. Votre écoute est significative.
Usted es muy importante, especialmente para nosotros aquí en The New Chemist Podcasting Group. Usted escuchando, es significativo.
Você é muito importante. Especialmente para nós do The New Chemist Podcasting Group. Você ouvindo, é significativo.
Είστε πολύ σημαντικοί, ειδικά για εμάς εδώ στο The New Chemist Podcasting Group. Το να ακούς είναι σημαντικό.
Sie sind sehr wichtig, besonders für uns hier bei The New Chemist Podcasting Group. Es ist wichtig, dass du zuhörst.
Je bent erg belangrijk, vooral voor ons hier bij The New Chemist Podcasting Group. Dat je meeluistert, is veelbetekenend.
You are very important, especially to us here at the New Chemist Podcasting Group. You listening in is significant.